So just to welcome you all, and we now have quorum, so we can make a start with Diane coming in online. Just to remind members of the sensitivity of your microphones, and it can pick up conversations that aren't part of the meeting discussion. Again, this week we have a very full agenda, so we have the department here to brief on the tobacco and vapes bill. Then we will have the Royal College of Surgeons who will be briefing us on waiting lists. And then we'll have representatives from the Royal College of Nursing who will update us on workforce issues. We then will have 2 statutory rules to consider. And as this is, we have a significant amount of business to get through. Time will be tight and time for questions will be limited. So if I could ask members to respect that when we're going through our different briefing sessions in particularly. So just I'll now declare the meeting open to the public. Members, the committee meeting will be recorded and broadcast throughout Parliament buildings and online. And if I could just remind members and anyone in the public gallery, although we don't have anyone at the minute, you're welcome to use mobile devices as long as they are in airplane mode, and all devices must be muted. And you can connect to the Assembly Wi-Fi. Password details are available in the gallery rooms, but we're not permitted for photographs or any recording of the meeting. With no other apologies, I think everyone is here at this stage. So just item number 2 on your pack is chairperson's business. There's just 2 things I wanted to raise. We had the Royal College of GPs obviously here last week, and on Tuesday we had the event in the Long Gallery, which I think was a very good event and was well attended. I think most of us were able to get in for some of that anyhow. So just to reference that, I think there's some important work coming out of their report as well. And just as well, members, I met with the Children's Health Coalition earlier in the week, and they have some asks around financial support for families who have a child who is sick. So obviously with the hidden costs of caring for a sick child, and I was going to ask the committee if they'd be happy to write to the Minister just to highlight this, because I know he is meeting with the Children's Health Coalition next week, and that we can ask for an update on that meeting whenever he comes, whenever they have that, if members are happy enough. Okay, thank you. Members, if I can refer you to the draft minutes at tab 3, page 6 of your meeting pack. Are members content with the minutes? And yep. And I've no matters arising if anyone else has anything to raise under that. No, Nuala?
No, I was just going to say,
item was it?
Yeah, but it's fine. My papers aren't working. Whereas they were working 10 minutes ago. Just
come do it again during the correspondence, so we can.
Okay. Members, I should have mentioned, as before we move into item number 5, I want to welcome we have some members here from the Youth Assembly, and some of us attended what was an absolutely fantastic event in the Long Gallery this afternoon, where we heard the views and feedback from young people who are part of our Youth Assembly on the LCM tobacco and vapes bill that we have been discussing. So just want to welcome them all here today. I hope it's been very worthwhile, and certainly from our perspective it has been really, really good to get the feedback we have. So thank you to them. I'm now going to move to the briefing, and we have officials with us today. So just the briefing papers at tab 5, page 18 of your pack, and the report from the Youth Assembly is also available in your pack at page 37. Page 6 of your table papers is some further briefing from the Institute for Public Health following its review on the health effects of vaping among children and adolescents, and the conclusion of that review outlines that there is strong high quality evidence that vaping among children was associated with harms to their health and future tobacco smoking. So we did talk a lot about that in our lunchtime session there with the Youth Assembly, and I think predominantly for the young people that took part, vaping is potentially an even bigger issue than tobacco smoking. So I think for us as a committee, it's something that we will probably want to do some further work on in the time ahead. So members, just before we go into the briefing, there's a draft press release in your table papers and in front of you. So I just want to ask members if they're content with the press release as drafted. Yep. Nuala? Yeah.
Yeah. No, I'm content with the press release. It's just I thought it was really helpful to have the actual report as well, and I just wondered if that is public, and if not, I think it would actually be really beneficial if something like that was made public for the public to actually. I know that we get a lot of contact by people, with regards to the evidence around vaping. So I just wanted to know.
Do you mean the Youth Assembly report or the Institute?
I'm just going to get the exact name up here. The Institute, the Institute, the Public Health one.
Sorry, Chair. They've done the work on behalf of the department. They've undertaken the review, so I have a feeling the department may well publish that at some point.
Okay.
But they were just giving us a overview of what it states. But I think the department's requested them to do the review, but we can pick that up with officials.
Yeah. Okay, members, I'd just like to welcome Brian Daly, who's head of the Health Improvement Branch, and Karen Oldham, Health Improvement Branch, and thank you for coming back to brief us on this. So I'll open up to yourselves.
Thank you, Chair, and thank you to the committee for inviting us back to provide you with a further update on the UK Government Tobacco and Vapes Bill. So when we previously attended on the 14th of March, the bill had not been introduced at Westminster. It was subsequently introduced the following week on the 20th of March, and the Department has now laid a legislative consent memorandum on the 26th of March. The second reading of the bill took place on the 16th of April, and normal procedure is that the deadline for Assembly agreement to a legislative consent motion is the last day for tabling amendments, so the report stage in the Commons and third reading in the Lords. So subject to the committee report being finalised around the 25th of April, our timetable predicts a legislative consent motion debate taking place towards the end of May. We hope around the 20th. And this would appear to be on track with the UK Government process. So the bill, as published, sets out a number of provisions falling within the legislative competence of Northern Ireland, hence the need for legislative consent. So we've outlined the provisions in the written briefing provided to the committee, and I'm happy to recap on those if the committee are content. That'll take about 6 minutes, or if you are happy to go straight to questions.
Members, I'm happy to go to questions because I think at this stage we've had quite a lot of information on it, so really appreciate that, Brian, and I don't want to delay you any longer than needed. I just have one question, I suppose, just to kick off in terms of the regulations, because we have asked quite a few questions over the last number of weeks. So just in terms of the regulations, which of them will be made and upheld by local ministers and which through the Westminster the government, and can we determine to see which of those regulations are actually the responsibility of which minister, if that makes sense? So we're just trying to clarify who will have responsibility for what elements.
You want to go?
So part 3 of the bill is the part that applies specifically to Northern Ireland, and that sets out the amendments that are required to introduce the smoke-free generation. So those provisions are on the face of the bill. There's no further regulations needed. They will come into force in 2027. Part 3 also then has a number of amendments, and those are introduce the regulation making powers that I think you're referring to, and they are amendments to the Health Miscellaneous Provisions Act 2016. So there's a number of things there that would fall then within the scope of our minister bringing forward regulations. Effectively, I'll just outline them very quickly. Non-nicotine vapes, age of sale, that's something we would be making locally, and that would be subject to draft affirmative process in the Assembly. There's a couple of sort of incidental things, such as sort of restricting the sales to retail, etc., which we can pick up if needs be. But to cover the big hitters, then there's the free distribution of vapes and other. That's non-nicotine vapes and all other nicotine products. That would include the current nicotine vapes, plus things like nicotine pouches that we're seeing more of, etc. So that would be free distribution to under 18s. Our current age of sale provisions don't cover that. We're not seeing a huge problem in Northern Ireland as yet with that, but we know other parts of the UK have seen that become increasingly used as a marketing technique. And I suppose we are conscious that there's a risk that once other restrictions are in place that would be sort of exploited a bit further here. So those would be locally made regulations, and again subject to draft affirmative procedure. And then we also have the powers locally to bring forward display of vaping and nicotine products and prices regulations. So that would be similar to the current provisions that we have for tobacco products. And again, those would be able to be made locally by our Minister and subject to the draft affirmative procedure. So those are the main things. Then part 4 of the bill sort of gets into the product requirements, and that's it restates some provisions that already exist in the 2014 Children and Families Act, which is a UK act. And that's around flavours and packaging restrictions for tobacco. So those powers already exist, but they're being restated in this bill. And I think that's just a protocol for clarity, etc., that happens when there's a variety of pieces of legislation. I understand then that those effectively are being mirrored, those clauses, in relation to vapes. So there will be new powers, and they will sit with the Secretary of State. And the intention would be that the Secretary of State seeks the consent of the devolved administrations to make regulations UK-wide in relation to those measures. So the intention is that there will be sort of close working on those particular aspects. And sorry, I will just mention here, because I know Diane asked last time around about content, that provision also allows for sort of restrictions on other content. So part 5 then similarly sits with the Secretary of State, those regulation making powers, and again with consent. We believe that most of this part relates to the notification requirements that exist for manufacturers in relation to putting e-cigarettes, currently nicotine e-cigarettes, on the market. So Northern Ireland are in a slightly separate or slightly different position to the rest of the UK in relation to this one, in that to notify products for the GB market upon EU exit. At one point we were all had to notify on an EU system, the EU Common Entry Gate. After EU exit, GB basically invented their own sort of parallel system. Northern Ireland still has to comply with that EU requirement to notify on that. However, what Part 5 seeks to do is to sort of extend those notification requirements to other products such as non-nicotine vapes and to other nicotine products such as pouches, etc. And if that were to happen, those provisions, because there's no EU rules around those could be extended to Northern Ireland. So those are that's sort of the division. The sort of, as I say, the product requirements, the notification requirements, the powers sit with the Secretary of State. The others sit with our Minister and Assembly.
No, thank you, Karen. And I suppose just on that, one of the things that you mentioned there around the free distribution, that was something I wasn't even aware of, and our young people pointed that out earlier in our session, because it's actually a huge issue, and we were quite shocked at the numbers coming back of children who had got their first vape through a promotional free of charge distribution by some of the companies. So I suppose certainly for myself that was real learning curve, and it's something, I suppose it's how they get the hook then to get them on to vape, and it obviously escalates from there. So thank you for that. Anyone I have is Nuala for a question?
Yes, I just wanted to touch again. We talked a little bit about the enforcement at the last session, or maybe the session before that, the session that you were at actually, and whether the department has given any thought or coordination to the Department for Communities any further around that issue of enforcement, particularly with local authorities, and if they will be given further assistance in terms of how they can enforce like quicker, better, but also just what is going to happen post 27 in terms of preparation for that.
And I think certainly, Brian, I'll maybe start. You can jump in if you something else. We certainly will be engaging with the councils. We have quite sort of tight working relationships with. There's a tobacco control group within the councils, and Belfast Council in particular is the body that sort of is in charge of the tobacco retailer register. So we have those close working relationships. We will be engaging further with them. We wanted to sort of see where this went and be sure that we have got that legislative consent. We will then be discussing with them the challenges and what they think the needs will be, the enhanced needs will be. I think it's probably fair to point out that there are already age of sale restrictions on tobacco that they enforce, but that's not to sort of dismiss the fact that of course there will be something more needed, including publicity and training, etc., and probably some kind of communication with retailers as well to those forums. So it is planned. We will be discussing with them. There isn't a ready pot of money to throw at this, of course. When England made the announcement, they had mentioned about the sort of enhancements that they're going to be making in terms of financial support for enforcement. There is a Barnett consequential from the announcement, the funding announcements, but of course that is something we will explore. Not sure how far we'll get with it, but we will explore that. But we will of course have to work out what the likely costs are going to be before we start sort of trying to make any case for funding.
Yeah, no, that's very good. With the lead-in time that we've got until it comes into force, we're hoping that we can do some awareness and some training and working with retailers, and there's lots of different things that we can do in the time that we've got to try and cross off that.
Okay. All right, Colin.
Thank you, Chair. Thank you for the presentation. I suppose I heard you a number of times just mentioning there that some of the things that we can control would be done by affirmative, the things we should know. It's secondary.
Sorry, yeah.
What do you call those things?
Affirmative procedures.
Affirmative procedures. But when they land with us, they're done. So we either support them or we don't. Is there any way that we could actually influence what they actually say? Because I'm thinking that today, especially with the Youth Assembly, they were making it very clear that the £100 fine they felt wasn't enough. That the distribution of free items, etc., was something that they were concerned about. But if the Minister was to take them on board, it would just come up to us as a piece of draft legislation that goes into the Assembly and either we approve it or don't. So it's really about, can we as a committee have some sort of influence at the drafting stage of that?
I don't see why not. Certainly there will be consultation on any regulations as well.
Okay.
I don't see any reason why we couldn't. And I'm very interested. I think you talked about the Youth Assembly. I think we would be very interested to hear that, because there's already information there that was mentioned that hadn't been on our radar. So absolutely. I'm sure we can look at that. Yes. I think we'll probably have to sort of work out what the timescales and the sequencing of regulations, etc. But we can certainly come back to you on that.
I can't see you being blindsided by this. There'll be an opportunity to consult at different stages.
And would that maybe finally, just Chair, would that be something that you might take away and consider, that maybe meeting with the Youth Assembly to actually, as part of a consultation process, to give them their place as a Youth Assembly, but also as it's something that impacts young people, hearing their views would be.
I think that sounds like a great idea.
It's something we can do, and also the PHA as well.
Yeah, absolutely. Okay, thank you, Chair.
Okay, thank you, Danny.
Yeah, thank you, Chair. I was with the Youth Assembly as well there, and certainly I was quite taken aback by some of the things they were saying. I thought they were incredibly thoughtful and incredibly thorough. The report was great. Vaping's a massive issue for them, whereas smoking doesn't tend to be. So I think we need to look a bit stronger on the vaping side of it. Now, it would appear to me that there's no regulations for vaping to be licensed. So is there any way to amend the legislation so that people who want to sell vapes can be licensed as well, in the same way that we license people who want to sell cigarettes? Obviously a nicotine product, a very addictive product as well. One other question as well. So from that question, just will there be a way that legislation will be able to be amended to bring in licensing of people who are selling vapes so that we can control them? Second question was the thing that came from the Youth Assembly again. A lot of the unintended consequences these guys were looking at. It was very, very thorough, as I said. One of the things that they were concerned about was illegal tobacco and the rise in other substances being smoked. Do you think that could potentially be an unintended consequence of this? And is there anything that you can do in order to hit that off? Thank you.
So, yeah, I mean, the sort of the first point about a retail register is one that has come up before, and I know there is an appetite for that amongst some of the voluntary sector. I think we maybe touched on this last time. Northern Ireland Chest, Heart and Stroke, I think you mentioned last time, I think are supportive of that, and we know that there is also support within the council's enforcement bodies for something like that. I think we referenced last time the difficulties they have in sort of identifying the vast variety of businesses that currently are selling these products. This bill doesn't contain provisions in that, and I know that England and Wales have indicated that they do not have an intention to bring forward a register. That doesn't mean that we couldn't do it locally. The Northern Ireland Audit Office, I think I mentioned their report last time we were here as well, they have also suggested that we look at that. We will be. We had started work on our strategy at the end of last year. It's been sort of slightly delayed as we look at this piece of work now. But I think that's certainly something we had planned to explore during the conversations on that strategy. It would require primary legislation. So you mentioned the tobacco strategy. We do have that. That was a locally made piece of primary legislation, and it would require primary legislation. So I don't think it will be an instant answer, but it's certainly something I think that we could explore further indeed. In terms of illicit tobacco and the contents stuff that you mentioned there, the bill provisions do extend to the other types of smoked substances. So the bill covers herbal type products as well as tobacco. I suppose it's difficult to know where to go beyond that, because there's obviously already laws around illegal substances. We hear about people's, particularly in relation to vapes, about spice and spiked vapes. So, and that also exists, I suppose, in relation to smoked products. So I would hope that some of that is already covered by existing sort of drugs legislation. But yes, certainly herbal products, which we understand are also contain sort of cancer-causing chemicals, are covered by the bill.
With the illicit tobacco, which I understand is already a problem, with cigarettes being sold illicitly, do you see that growing, expanding?
Well, no, not necessarily. I mean, I think, as you say, it's already there, but it's as with all of those illicit products, it's fueled by addiction. The demand is fueled by addiction, and so I suppose the intention of this bill is that we're going to reduce that addiction, and hopefully that will have a positive impact on that those illicit products anyway. I mentioned earlier just about the money that England has announced. Part of that money will be used to fund or to enhance funding to HMRC and Border Force. To sort of deal with illicit products. They recently published a joint strategy as well in relation to illicit tobacco, and I understand there's a task force being set up as part of that strategy, which will sort of expand on existing arrangements, and will also look to sort of enhance intelligence with other countries where things are being imported from, etc. So there are measures in place to try and deal with that. I suppose that's really as far as we can go in terms of reassuring it at this stage. But
yeah, in the past when they aged the rate of sale of it actually reduced the amount of illicit trade. So facts from the past would tend to indicate that when we do these sorts of changes, it actually helps reduce illicit, because you're reducing the addiction.
Thank you.
Okay, Diane.
Thank you, Chair. So just following on from Danny's question, which I think is really interesting, how much will the bill and the delegation to Northern Ireland allow us to regulate the content of vapes?
So the powers in relation to content fall within that part 4 of the bill that I mentioned, that deals with issues such as content, flavours and packaging. Those powers sit with the Secretary of State at present, but regulations would be made with Northern Ireland and the other DA's consent. There is an intention that we work jointly and together on developing such regulations. So it would be a case of, I guess, I don't know if you have particular contents in mind, but I guess we're talking about chemicals and other such things. So would probably have to be an agreed position across the DAs and England and Wales at this point.
So are you saying that as of now, the bill does not help us to regulate the content of vapes? I mean, the tobacco industry, whatever you think of it, and I am very anti-smoking, but is a highly regulated industry. The vaping industry is not. And it seems to me that we need to take steps to actually start to regulate what people are buying, because one, they're new. This is a new device, a new phenomenon, relatively new. And we have precious little research to understand what the current position is and the impact on health. And it would seem to me that the bill would be missing a trick if we couldn't actually then start to regulate in terms of people's health. What was actually in vapes, but you're saying the bill as it stands does not do that. Am I correct?
The bill provides powers to do that. So the bill provides regulation making powers, and the intention is that there will be regulations. And in fact, I think we're looking at probably regulations by sometime next year, I think is the initial suggestion. But what they have said is that there's been a commitment, and there was a commitment given in the debate on Tuesday to further consultation on any regulations made under that section. So there will, and I think the intention is that will be evidence-based, the decisions made in terms of what those regulations contain. So yes, the intention is there. There will be action taken to address that. It's just that we need to sort of fine-tune the evidence base to know exactly what those regulations need to contain.
Okay. And can I just ask, what are the exact notification requirements to the EU for Northern Ireland under the changes to the legislation?
So there won't be any changes in terms of the EU notifications. So any basically what they're allowing for within the bill is regulation making powers to allow the GB part of that notification system. So as I said, they've basically mirrored at this point the EU requirements in their own GB system. The powers within the bill will allow for that system to be extended to other products that are not currently covered by the EU, so that those could be applied to Northern Ireland. That would be non-nicotine containing vapes and other nicotine products. So at the minute, those aren't. There's no notification requirements in relation to those at EU level. So that would, as I say, those could apply to Northern Ireland. Then beyond that, the provisions would allow for the UK government, for the Secretary of State to sort of refine exactly what types of information they want to be captured in relation to those products, and for themselves they could do that in relation to nicotine containing vapes as well. In terms of the actual type of information that is currently required to be reported, I think there's a wide range of it, but it includes stuff such as the type, the content, the way the product's been manufactured, the sort of name and contact points within member states, etc. So there is a list of it, which of course I can supply if needs be, but there's a wide range of requirements at the minute.
Right. So Northern Ireland's notification process won't change in terms of nicotine, as it currently stands with the EU.
That's right.
Thank you.
Okay.
Thank you, Chair.
Thanks, Dan. I've no additional questions. Oh, sorry, Alan Chambers.
Just a very quick question. If you can confirm the current situation is that if a young person goes into a shop and tries maybe to hoodwink the retailer with fake ID, and if the retailer falls for it and sells a tobacco product, they have committed an offence. They may have a defence in court against it, in the circumstances, but there's no deterrent for the young person to try that, to do that. And I know it would be an extremely difficult thing to police, but there's going to be a lot more of this going forward, more age controls and more onus on retailers to avoid being prosecuted. Has any consideration been given to bringing in any form of deterrent to stop young people trying to use fake ID and so forth to actually purchase tobacco products?
No, not that I'm aware of. I think there has been quite considerable concern about criminalising children in the past in relation to this. So the offences are, as you say, sit with the retailer or anyone proxy purchasing on behalf of children. So no, there's nothing that I'm aware of in the pipeline, either locally or at UK level. And I think possibly you could argue that if there was to be something that extends beyond tobacco, it would be in relation to any age restricted products, you might have to consider that. But no, there's certainly nothing we are considering at the moment.
There is research, I think, into age identification as an issue generally, which might be applicable to this in future. And there is a sort of an age notification system in Scotland, isn't there? If the shopkeeper thinks the person is under the age of 25, they're obliged to ask them their age. And that doesn't, well, it's only in Scotland at the minute, but that's the sort of thing that might be considered in future as well.
Thank you.
Okay, Karen and Brian, thank you very much. That's definitely been very helpful, and I suppose we've had quite a lot of information to date, so it's certainly been useful for the committee. I appreciate your time. So
Thank you.
Thanks very much.
Very much.
Thank you.
Okay, members, I suppose that concludes all the evidence sessions on the LCM that the committee now needs to decide if we actually agree with the LCM or not. At this stage, has anybody any views they want to put forward before I put the question? No. Okay, so just to ask the committee then, are we agreed to support the Minister in seeking the Assembly's endorsement of the legislation? Agreed. Okay, thank you. The committee team will draft a short report outlining the committee's consideration of the LCM, and this will be sent out to members for consideration and agreement early next week. So thank you all for that. Members, item number 6 then is we'll have the Royal College of Surgeons in attendance who will provide a briefing on waiting lists. Your briefing paper is at tab 6 at page 50 of your pack, and also in the members' pack in correspondence at page 135 is the Minister's reply to the committee following the Department's briefing on waiting lists. Again, as we're tight for time, we'll have an hour max for this section, so if I could ask members to remember that when you're asking your questions, as I will be trying to move through them as quickly as we can. You're all very welcome. In attendance today we have Niall McGonigal, Royal College of Surgeons Director, and Anne Garhy, OMFS Consultant, Claire Jones, Hepatopancreato Biliary, we got it right, Surgeon, and Martin King, a General Surgical Registrar. So you're all very welcome, and we appreciate your time here today on what is a very important issue for the committee. So if I can invite you to make your opening remarks.
Thank you, Madam Chairperson, and thank you very much to the committee for having us today to give evidence about the pressures we face and the unprecedented waiting lists for the people of Northern Ireland. We will focus primarily on 4 pertinent issues: waiting lists, workforce, surgical hubs and surgical training. But before I come to our remarks, I would want to highlight to the committee that the Royal College fraternity has raised a red flag in the last couple of weeks, perhaps even an SOS to yourselves about the stresses of working in our health service and the level of service that we can currently provide to our patients. The Royal College of Paediatrics and Child Health produced a report highlighting the devastating waiting lists for children, with a 172% jump in outpatient waiting lists from 2016 to 2023. Then the Royal College of General Practitioners this week launched their workforce document highlighting the huge strains in primary care, with 18 practice handbacks in the last year. The Royal College of general practitioners appeared in front of the committee within the last few days as well, highlighting the unprecedented demand on the services and the problems in retaining GPs. This is the same throughout all components of the healthcare system at present. In surgery, we too are facing huge difficulties in terms of daily work and also trying to address a backlog that has existed for over a decade. And I know that the Royal College of Nursing are speaking to you later today after this session, and I imagine they will be saying the same things about working on the front line and highlighting the significant challenges faced day and daily by our healthcare workers. Members of the Health Committee, I think it's fair to say that despite best efforts, we are in dire straits and action must be taken for the people of Northern Ireland. Moving on to our formal remarks, presently around a quarter of Northern Ireland's population is on a waiting list, either to see a consultant for the first time, for a diagnostic test, or for elective inpatient treatment. And that in a population of 1.9 million people equates to 26% of the population. This figure for the same metrics in England is about 12%. Anecdotally, when we break down components of the orthopaedic waiting list, we see that in order to clear those waiting lists, it would take all-day operating 7 days a week for 3 years. The scale of waiting times are so severe now that we know patients are coming to harm, conditions are progressing, and they are becoming more complex. This can lead to more difficult operations and, unfortunately, in some cases, where surgery is no longer possible. They can increase the morbidity associated with the procedure, but also the amount of time required in an operating theatre to complete that procedure. We must also not forget the psychological and mental health implications of these prolonged waits, almost always without information on position on a waiting list, and also the likely time to treatment on that waiting list. Simply put, delays cost more, both financially and in the well-being of our patients. When I was 17, I had a chest wall deformity called pectus carinatum. This required extensive chest wall surgery. I had my operation within about 6 months. That's more than a few years ago, needless to say. But today I am seeing young people with exactly the same condition and putting them on a waiting list for the same operation. And I know realistically that there are people on that waiting list that are on it for approximately a decade. Now, we have done some work recently on some of our longest waiters, but again, this is non-recurrent funding and it is very difficult to manage that. We are constantly in the stop-start situation, and that is very deeply frustrating to patients and surgeons as well. Today's health service is not one that we can be profoundly proud of, and certainly not one that our patients deserve. Everyone involved wants this to be better for our patients, and that includes yourselves as our elected leaders, but also as potential patients, or perhaps as the mother, father of a potential patient, or the son and daughter of a patient. As surgeons, we want to deliver for the population, but we also want better conditions for surgeons to deliver what can be life-changing and life-saving surgery. The moral stress is not insignificant. Knowing that our patients are waiting on outpatient appointments and surgery that can stretch for 4 or 5 years, or surgery for children that can be in excess of a 4-year waiting list, is not acceptable. It is clear that we need to do things differently. We have a falling birth rate and a rising older population. The impact of these demographic shifts are being felt across elective care, primary care, emergency departments, and our community care services. We can no longer to accept these figures because behind every number there is a person. Committee, thank you for inviting us, and I will pass you over to my oral and maxillofacial surgery colleague, Anne Garrigy, who will talk you through the workforce pressures in more detail.
Thank you for this opportunity. So in January 2024, the College published a UK-wide surgical workforce census report. Across each of the nations, the situation showed a workforce struggling to meet demand. From a Northern Ireland perspective, census respondents showed that 53% of Northern Ireland surgeons have considered leaving the workforce within the past year, and 91, 9 out of 10, surgeons aged 55 to 64 say they plan to retire within the next 4 years. 66% of those who responded reported a lack of access to theatre lists, and 48% saying the system challenges had an impact on their ability to deliver their work. Subsequently, Consequently, we have 66% reporting burnout and stress due to the excessive workloads. This is a highly skilled cohort of doctors who care about their work and want to do the best for their patients. The fallout from a burnt-out workforce is services becoming adversely affected and recruitment efforts becoming harder. The college recommendations include increasing productivity, surgical hubs being part of this, and Claire will talk about this further. But there is a need also to maximise the use of current resources, both staff and facility, and to continue to have a clear, well-planned and funded regional approach to the problems. Surgical teams unable to achieve their full potential due to a lack of theatre access or staffing is a waste of resource for the region. Those teams will become disillusioned over time, and this is reflected in the feedback from the report. The second recommendation of the census report says that we need to ensure we have a sustainable surgical workforce. As well as having a good working environment, we need to increase the training numbers in all surgical specialties, and Martin will update you on the current challenges pertaining to recruitment. The census report also recommends changing the way the surgical team works. So surgery is changing, and we need to update job planning guidance to reflect career stage, bearing in mind challenging emergency and elective variations in practice. We also need to make sure there is protected time for surgeons to train members of the surgical team, training our successors. And finally, we need to make sure we are inclusive of all of our team members. Working together as a team underpins all chances for success, especially in the face of major workforce pressures. Now, looking to getting it right first time, they have come into Northern Ireland and undertaken significant service reviews into trauma and orthopaedics, gynecology and urology. Teams from the same entity are also on their way to look into ENT, paediatric orthopaedics. Learning to do better, reach best practice clinical standards, and adapt our way of working towards systems that work elsewhere in the UK is important. However, clinicians need time, space and investment to do this. Changing the way a service is delivered, for example, towards a regional outlook requires long-term planning and investment, and we can't expect effective delivery on a shoestring. And if we want the health service to remain free at the point of need, then we need to act fast. We, like other parts of the system, need a lifeline so that we can get on with the job of helping people get better by helping them get their surgery sooner and more quickly. And I have worked quite recently elsewhere in the UK, so I would be happy to take questions on comparisons if that need arises. Okay, Claire.
Moving on, we're very mindful of the massive pressures on the surgical services throughout the entire province at the moment, with a workforce that is increasingly stretched and stressed. However, one of the positive developments that we want to focus on today is the identification of day procedure units, or the elective care centres, the EOSCs we hear talked about. And these are particularly important, bearing in mind that 2/3 of the waiting list actually are day case type procedures. This follows on from a college document, 10 Steps, Not 10 Years, which highlighted that the right resources and focus, Northern Ireland could see the restoration of timely access to surgical treatment, which includes creating and expanding the existing surgical hub model. So thus far, the model has yielded significant results. I'm just going to outline a few of those. So Lagan Valley Surgical Hub has completed 13,000 cases. OMA, Day Procedure Unit, 500 patients. The South West Acute Hospital Elective Overnight Stay Centre, 312 patients. The Mater Overnight Stay Centre has had 2,842 patients through the doors, and Daisy Hill, 6,000. In addition to those that I've already discussed, patients can now access surgery in the Orthopaedic Surgical Hub at Musgrave Park Hospital, which includes a dedicated orthopaedic day procedure centre. Rapid diagnostic centres at Omagh and Mid-Ulster, cataract centres at Down, Omagh and Mid-Ulster hospitals, and protected regional surgical and specialist services in Belfast City Hospital. This has also been helped by the expansion of what we call as PACU, which is a post-anaesthetic care unit in elective care centres. So in terms of inpatient lists, it is important to flag some improvement in inpatient waits over 13 weeks. So if we look at figures from September 2023, 78.6% which is 91,131 patients, were waiting more than 13 weeks for admission. This can be compared to 79.8%, which is 100,893 in September of 2022. Patients waiting over 52 weeks, so over 1 year, have also reduced regionally. 51.9%, which is 60,161 patients waiting more than 52 weeks in September 2023. This can be compared to 54.8%, which is 69,321 in September 2022. However, the success of the surgical hub model in the long term will not keep evolving unless we have a resilient, flexible workforce of sufficient size and comprising of staff with the appropriate skill mix. We also need to future-proof surgical care, as we have, as I think we've addressed previously, that we have an ageing population who have increasingly complex needs. So I'll move on now to Martin, who will talk about the surgeons of the future and surgical training.
Thank you, Claire. Good afternoon, committee. Thank you for the opportunity to speak to you today. As a surgical trainee in Northern Ireland, I would like to briefly cover 3 key points: the relationship between a consultant, trainer and the trainee, the current experience of surgical trainees, and the future of surgical training. In Northern Ireland, there are 205 surgical trainees across core and 10 higher surgical subspecialty training programmes. As a craft-based specialty, the consultant surgeon remains the main source of training, and without a stable consultant workforce, surgical trainees will not be able to sustainably nor safely support the growing needs of our aging and increasingly comorbid population. The reconfiguration of access to care through development of surgical hubs is to be celebrated. It offers that chance to both tackle waiting lists and develop the future workforce. Whilst we don't yet have that objective, clear data to assess how many trainees access these opportunities, other than through personal experiences, it is important that we assess that impact on experience and skill mix. Should the 91% of surgeons in the census aged between 55 to 64 retire in the next 4 years, a statistic that training organisations hope never comes to fruition, we have major concerns that we and future colleagues will not be adequately prepared to replace consultant colleagues. Therefore, the acute needs of our service needs to be balanced alongside supporting consultants to train, and failure to do so will worsen an already difficult situation for patients accessing care. Ultimately, no training today, no surgeons tomorrow. Moving to the current experience of trainees. Doctors in surgical training face unique challenges, including some of the longest training times, more than 10 years from graduation in some cases, assuming high personal financial burden for career progression. There are also serious non-financial challenges facing them, such as poor work-life balance, poor physical and mental well-being, affecting their progression and retention in programmes. 76.8% of respondents to the Association of Surgeons' recent Cost of Surgical Training report highlight training as having a negative impact to their physical health, and 84.3% reporting training as having a negative impact on their mental health. The issues that this committee are acutely aware of across health and social care, staffing levels, the rotational nature of our training, and the rota patterns are all contributing factors to those statistics. In that UK-wide survey, it was also highlighted that half of trainees are considering practicing in another country due to the non-financial costs of training, and this is more likely for younger trainees. However, the data captured in this survey demonstrates that uncertainty about the future spans all stages of training. At junior levels, it is related to recruitment processes, career progression, bottlenecks in being recruited to the programme, limited by training numbers, and the associated need to move around in order for career progression. At senior levels, it is related to the rotational nature of the training programmes, the often unpredictable location of the next rotation, given at short notice, resulting in frequent relocations. At all career stages, uncertainty regarding the future affects personal relationships, mental health, family dynamics, friendships, hobbies, and the ability to engage in parenting roles. The report includes recommendations that we will be happy to share with committee. Looking to the future, technological developments such as simulation, robotics, genomics, and artificial intelligence are likely to alter dramatically the nature of how surgeons provide surgical care, and in many cases some already are. Over 70% of surgical trainees view robotics as important to their future career and specialty. Indeed, the 2022 Department of Health Cancer Strategy highlighted that delays to the implementation of new technology may also result in inequitable access to the best standards of care in the future. Currently, there is only one robotic system in one specialty in one trust in Northern Ireland. And despite the aforementioned, applications to surgical training remain extremely competitive in a global market across the UK and Ireland. Training recovery needs to be more strongly embedded into elective recovery. And I end with a quote, train one, treat many. Thank you very much.
Thank you all. That was very comprehensive, and just I suppose to say as well, the briefing paper provided to committee was really, really good, and it's certainly been very useful for us to prepare for today. So look, a lot of information there, and I think it's been useful to get it in under the headings that you've provided. I have a couple of questions and then I'll open up to members if that's okay. In your briefing paper, and I know diagnostic scans are not primarily the work of surgeons, but obviously they are a huge element of the waitlist picture. You quoted that there's currently just under 190,000 patients waiting on a diagnostic scan, and you have talked quite explicitly there about the need for us to use all the resources available to us in that. From what you're saying, and you've said there about, you know, the importance of someone being seen early to be able to get the best treatment if required, because the later stage it is, then obviously the greater the impact. What impact is that having on those people that have been sitting on wait lists for far longer than they need to be when they get to the stage where you're seeing them?
Excellent question, and I don't think it would be difficult to sort of extrapolate from the fact that, you know, disease is something that progresses over a period of time, you know, so from one time point to another. Therefore, if you are waiting for a period of time, that disease is progressing. Now, it may not, if you take sort of the non-malignant disease, so take away the cancers and stuff like this, people are still deteriorating over a period of time. That means, you know, the condition is worsening whilst they're waiting for an investigation that was required for something else. I think one of the good things that maybe have been talked about already this week was from the GPs about the fact that you know, patients were put onto multiple waiting lists because they were engaging with ED departments and stuff at different times as well. That's because their disease is getting worse over a period of time. They're waiting. They're going to their GP 17 times. They're going to ED 5 times. You know, the gallstones are getting worse. They're running risk of cholangitis, infection stuff within the gallbladder. So there is that progression as well. When you then do come to sort of the other end of it, the red flags, the malignant disease as well, those delays do reduce longer term survival. There is no doubt about that.
Oh, no, thank you. And I'd alluded to at the start of the briefing that we've also received a response from the Minister in relation to our recent briefing on wait lists, and we saw some very stark figures about waiting times for bowel cancer treatment. And something that has jumped out at me is that for those people who, from the time of referral by their GP to the time of their first treatment, none of the trusts are even coming close to meeting those target times. And it seems that the bottleneck is around that period between the red flag referral to the diagnostic scan, and it leads into the next question, and it may be just for a comment from yourselves, from your perspective as at the surgical end. Something that's been brought to my attention very recently from patients in my own constituency, and I'm in the Southern Trust area, is that red flag referrals ultimately are being delayed, which we are already acutely aware of. However, those patients who are on a 6-monthly scan for someone maybe particularly with a history of cancer, where they're required to go for regular checkups, are now seeing longer and longer delays for those scans. And I am aware in Daisy Hill in particular, and maybe you can't talk, but it leads into that issue around using all the resources available, that we have a scanner there that's not used over the weekend. And I am sure that is something that we should be looking at to try and address some of the backlog that we're talking about here. So I don't know whether it's something you maybe can't answer on, but I just wanted to point that out because it's been brought to my attention, and I think we're talking about waiting lists and we know there's the financial picture, but this is something I think that we could be looking at very, very quickly and we should be using. So from a surgical perspective, is there anything you could comment on around that?
You're absolutely right. You know, the analogy that I would always look at is, you know, from the airline industry, they say when an airplane's on the ground, it's not making money. It's much the same in healthcare. We have this infrastructure, we have these facilities, we have these scanners, but most of them work 9 to 5, Monday to Friday.
Yeah.
There is absolutely no reason that we couldn't be extending the working day to use them longer and longer, 8 o'clock to 8 o'clock, 8 o'clock to 10 o'clock, doing them at the weekends. And you're right, not just, you know, scanners, but operating theatres as well. We have operating theatres and the equivalent of, you know, day case procedure units sitting fallow.
Yeah.
We, you know, look at Southwest Acute Hospital. You know, they've got 2 day case units for doing OGD scopes. Only one of them is actually commissioned at present. So we have those facilities there, but it's about using them.
Yeah. And I suppose that then leads into my next question. You've mentioned around the elective care hubs, and again, being parochial here, but you mentioned Daisy Hill, and it's great to see the figures coming out on that, and Lagan Valley and another one, very, very high figures, which is undoubtedly having a huge impact. And earlier in the week at the Royal College of Paediatric, their event, the Worried and Waiting event, I spoke to some of your colleagues there, and we had a conversation around how scheduled and unscheduled surgeries are currently managed, and I think that's something we should be looking at as well, because if we can maybe separate some of those, it might help. So just to get your view on that as well, of what you think may help in terms of reducing those existing waiting lists for scheduled care, and how we manage then unscheduled surgeries.
Yeah, so I think that's a very good point, and I think the elective care centres have shown that actually by separating unscheduled care to sort of elective type care, separating those and keeping them separate allows the elective care to continue, and especially I think during the winter pressures times, those types of centres become really key to delivering surgical services. As you say, when I quoted the figures, you can see that there's a difference in the numbers across the elective care centres in Northern Ireland, and I suppose they are very much in their infancy, but certainly as surgeons we are very keen that they are further developed, that there's further potential funding to allow those to operate. As Niall was saying, you know, as surgeons we're happy to operate as whenever we're required. It's not necessarily Monday to Friday 9 to 5, in order to ensure that we can provide maximum benefit to the maximum people across Northern Ireland who need it. So it is about looking at how we use those, how we improve them, and how we improve the efficiency of them.
Yeah, so essentially expanding the elective care framework so it's fully implemented would be very beneficial.
The key that you're talking about is that ring fencing. It is removing the two. There are 2 components essentially. There's scheduled and non-scheduled care, and if you try to utilise and work with both of them together, it's not going to work well. And that is being demonstrated throughout the whole of the UK and elsewhere, that when you have such things as the surgical hubs, they are dedicated units. They are ring fenced. What is going on in unscheduled care does not affect it. You have separate teams, you have separate beds. That is what allows throughput. Unfortunately, particularly in my own specialty, which is thoracic surgery, you have thoracic surgery, cardiac surgery, you have vascular surgery, you have neurosurgery, all in a base that is also a major unscheduled care hospital. So when you don't ring fence, you cannot deliver that service.
So people are constantly being phoned to say they're being cancelled, and that the untold stress of that can add, I suppose, further to people's health conditions.
Sorry, just to follow on from that, I suppose that's the benefit of the way now the City Hospital has been monitored, or has been changed to being the elective centre for some of the cancer specialties, so colorectal cancer, esophagogastric, my own specialty, HPB, the Urology and Transplant Centre. So by that being an elective site, with the PACU that I talked about, which is the post-anaesthetic care unit, that has improved efficiency and flow, so we're not impacted in the way that Niall's specialty and other specialties are on the Royal site.
Okay, I'm just going to ask 2 short questions, and I'll let you answer, then I'll open up to other members. Just in relation, I suppose, to the following on from the elective surgery piece, you mentioned in the briefing paper around Encompass on the impact it's having and obviously we're still in relatively early stages of the rollout, but just if you could provide a wee bit more detail on that to help us understand, because we've recently had a briefing on the rollout of Encompass, so that would be useful. And I suppose just my second question very quickly, it relates to the workforce issues, and Martin, you outlined very clearly where we need to be going. We've been hearing obviously around locums and the use of locums, and I suppose the huge amount of money that is spent on that. Do you feel that over-reliance on locum staff is a major issue in terms of equity of care as well? So thank you.
Well, I'll take the question on Encompass. I work in the South Eastern Trust, which has gone live, and I have experience of electronic records in other units. I worked in the northeast of England, where we went electronic about 3 years ago, and it certainly demonstrated its merit that you could have your surgical practice, the equivalent of medical records, in a laptop, and we could take it off site. So there is certainly merit in the system, the transparency, the accountability, having oversight, but it is challenging to be working through the introduction of Encompass and EPIC as it's called elsewhere, and we are getting feedback. I have colleagues who work elsewhere, and we're seeing Encompass some way down the road, and there are some ongoing challenges. The practical aspect of learning to use a system that is clinician heavy, taking on some of the administrative roles, because it emerges from an American office-based model, and also longer term the effect it can have on capacity, because of the challenges that it faces. So a benefit, but not without some cost.
Okay, thank you.
Thank you for your question. In terms of equity of access, I'm very mindful of when the Trust CEOs made evidence to committee in relation to the fiscal position of trusts and where we are, and obviously the reliance on agency and locum staff is a huge issue in the current climate. What we outlined in the 10 steps, not 10 years, and our submitted evidence is that we are calling for more training numbers within the region. And in relation to the specific point of equitable access to care, ultimately what the college want and trainees want is to remain within the region and to provide that care that's sustainable and safe, and having temporary access to care and not that guarantee of a provider or a consultant being available to sustain that service will undoubtedly result in inequity of access to care. So I think there is a demand from people wishing to work in Northern Ireland, but the funding in relation to the training numbers to guarantee that sustainable pipeline is yet to be clarified, and I'm very mindful of some of the work that the department's doing to forecast what that could look like into the future, and it'll be important to have that available on an annual basis to see whereby the workforce currently is and where it's going based on consultant retirements.
Yeah, thank you. Thanks very much. I have Linda.
Thank you very much, and some of my points have been covered, so I'll try to keep it as brief as I can to let others in. But you talked about some of the answer to this would be having different times in terms of having 8 to 8 for theatres and potentially for the diagnostic process as well. What is the biggest challenge to actually doing that? Is it just simply because it's not being done, or are there genuine reasons why it can't? Is it workforce? I suppose is the first thing. If we don't have the workforce to do it, then it can't be done. But is it just that we're not doing it?
I think probably most of it is down to capacity, in that we are utilising capacity as much as we can at present, but there probably is a lack of ability to upscale that capacity, and a lot of that is unfortunately down to workforce, because when I look at it particularly from a nursing perspective, I will work with a group of nurses in my theatre. They will work with us on a weekly basis, but often then at weekends and stuff they're off doing shifts elsewhere. So I think it's not that people are doing just their job. People are doing their job and working beyond it as well. So to try to increase that capacity, it's not really there.
Okay, so there is a workforce issue there that we need to address before we can increase those hours. So just in terms of the getting it right first time, so every time I ask about anything about women's health, particularly around surgical procedures, particularly around things such as endometriosis and the care or lack of around that particular issue, getting it right first time is the answer I get. How realistic is it in the current currently where we are sitting at this moment in time, that we are going to get it right first time, because I am aware of a number of women who've been in contact with me about all types of surgeries that they didn't actually need. So this is wasting time for yourselves, doing surgeries that were not the right surgeries. It wasn't got right first time, it wasn't got right at all. They were getting the wrong surgery because they weren't being properly diagnosed for what was wrong with them. Now that's a diagnosis issue, and then they're being forwarded on for a surgery that's not always necessary. Can I get a wee bit of an idea around how realistic that is, or can it be done where we're sitting at this moment in time? I don't want us to wait till we have a women's health action plan for women to start to get the right treatment, I suppose is the...
I think to be clear, women's health will fall under sort of a separate college. It's the College of Obstetrics and Gynecology. Obviously, very concerning to hear that people would say, well, they were given the wrong operation. But I wouldn't
not being
want to
sent
comment
to Gynae.
on that.
That's the problem. So
well, I suppose that is part of the issue as well. It is those massive waits, but the question is, where are they being sent then, and why is that service not happening? Because that is possibly part of the problem, is that has always happened in most healthcare and stuff like this, is that where there are long waitings in one place, somebody might try a back door somewhere through a different specialty to have somebody access that way. But again, it's coming back to people are waiting long periods of time. So what might have been the right and appropriate treatment now, 2 years, 3 years, 4 years down the line, is not the right thing, and things have changed.
Martin, is it a training issue?
So, again, similar to kind of the college, OBS and Gynae trainees fall under different remits, and I have no representation of OBS and Gynaes, unfortunately. I've been past president of the Association of Surgeons in Training for the UK and Ireland, and acutely aware of some of the training issues. But in regards of accessing it, I do think sometimes it's important to say that the workforce issue that I've highlighted today also applies for non-surgical specialties in OBS and Gynae. And I think that's something that could be translated, but I can't really speak to the specific question you
and that's fair enough, and I don't want to put you...
But I think a good point in the fact that, that this is not just restricted to surgery. This is all the components of our healthcare delivery system and service at the minute.
That's the point I'm trying to get to,
everywhere.
Niall, is that are people being referred to you for surgeries, for example, to any of you for surgeries, because there isn't the specialism or the understanding at the starting point of what is wrong with them and where they should be pointing them, and you're ending up with patients or at least people on waiting lists, and by the time they get to you, you're saying, wrong place, shouldn't have been here, shouldn't have been on this waiting list. I suppose and this is more of a point, the waiting list is a problem, but there are so many people that aren't even on a waiting list, and they are in their thousands without a doubt, and they are never being seen, they're never on a list, they're not in those statistics, but their families are losing them, and that's the reality, and it's very much because of the position that you're in that makes people think, I'm not as bad as somebody else, so I'll just not, which is concerning. It's not something you have control of.
You're absolutely right, and the one thing that I could talk about in my own specialty is the fact I have a particular interest, for obvious reasons, in chest wall deformities. I know that there's an awful lot of young people that don't get referred. Why? Because they do go and see their GP who goes, well, there's a 10-year waiting list there. So, to be honest with you, there's not really much point.
And it's life impacting, because I actually dealt with a family that were in that very situation, and it was impacting every part of that young fella's life. Thankfully, he's had the surgery. One last question, if it's okay, Chair. Just, you said you worked in England?
Yes, I worked in the northeast of England.
I'm always trying to find out, is there things that we could be learning, best practice, or don't do this, was tried, and we should not even think about it? Well, particularly if it's something that we're talking about doing, that we should not be considering.
Well, the one comment I would make is that there's a certain amount of, not so much fragmentation, but I've come from a trust that is nearly as big as as Northern Ireland. I, at the moment we're going Encompass one trust at a time. We went Encompass, went live on electronic records on over 2 days, one initially for inpatients, then for outpatients. So I'm looking at I've come from a much larger system, and they're moving patients around. So we talked about capacity of diagnostics. You know, a patient will be told you'll get an appointment for a CT, possibly somewhere in the Tyne Valley. Even if you've never been there, go to the appointment because that's where we've set it up. It's, I don't know if it's economy of scale, but it's interesting to see how a single trust can work differently to a multiplicity of trusts. Patients also are, the Northeast is probably a good example. In some areas it's very sparsely populated and patients will be required to travel. But I think if they're joining the right queue, they're prepared to do so. If you live in Northumbria and you're right up at the Scottish borders, your nearest big centre is Newcastle. We had patients in Newcastle who would come from Whitehaven, which is the far side of Cumbria, because there was concentration of the services and perhaps focusing of the resources with the requirement for the patients to travel.
And that's fair enough, and I agree. I don't think anybody has any problem. We know that people are travelling everywhere at this moment in time. It's about us making sure that the departments work together to ensure that they have a way of travelling, and that's an issue outside of your control or even the health departments to be. Thank you, Chair. Thank you.
Lula?
Thank you, Chair. Thank you very much for your presentation. And there are some figures in there that should frighten the public, but most importantly should frighten the Department of Health, because if it continues to spiral out of control, then at what point are they going to be able to catch up, and quite possibly never if they don't, particularly when it comes to the 9 and 10 aged over 55 wanting to retire. So my first question would be, and maybe it is for yourself, Martin, is do you actually see those people able now to come up and fill that gap? And how long do you think it would be before we're actually able to fill that gap? And then I have other questions after that, but if we want to start with that.
Thank you. So first thing is there's a concern. That concern has been flagged 2 years ago. It's not just a concern here in Northern Ireland, it's across the UK and Ireland. And that is with the fact that the people who do train us to provide that service are expressing that desire to leave. And when you begin your training, you hope to finish your training, but if you have no one to train you, then you have that concern that you're not going to develop that skill set, of which I would say cannot be rushed due to patient safety. You do the curriculum, the training that we follow is defined for a specific reason, and that is in order to be a day one consultant. And in 2022, I, along with other chairs of training organisations, wrote a statement during the COVID period flagging our concerns that the downturn in elective activity was going to have a huge impact in the next decade in relation to the skill set that would be able to provide a service. And therefore, that's in my remarks that I made at the start, is that trainees are in this with consultants. In other words, we want to support the consultants as much as the consultants wish to support us in order to deliver high quality care. And I would speak on behalf of any surgical trainee who enters the programme, is fundamentally that's what they want to do, is to provide the best operation at the best time for the patient.
Can I just say something about that as well? Just with another thing that I do is I'm the Deputy Head of School of Surgery for NIMDA, the training organisation. And to clarify, some of what Martin's talking about there, to solidify it, is I'm responsible for core surgical training, which is surgeons at the start of their training before they go off and specialised. And when we were part of national selection for that, we would appoint approximately 40 surgeons each year. When we were part of national selection, which was for the whole UK wide, we could only ever get about 6 for 40 posts. We now do it locally, and we have to interview in excess of 200 people to fill those 40 posts, because we struggle to get junior surgeons to come to Northern Ireland. And about 50% of them that get appointed are either international, or usually international medical graduates. They're a much more mobile group, so a lot of them choose, once they've done that, to leave. Mm-hmm. So it's about attracting people into the specialty and saying, when you come here, we would like you to stay, and this is how we would like you to stay. This is how we are going to facilitate you to stay.
And I think that's key, and the department needs to listen, and us as a committee will push them in order to actually implement some of the measures that can actually make you want to stay in the workforce, but also ensure that you can bring up those trainees. And I think that's important for us as a committee to hold fire on too. I also wanted to focus a little bit around surgical hubs. The department was up at the committee on the 21st of March, and I asked the question around the maximisation of the theatre space in particular. I think it was the SWA that only is using 1 out of 2. I think that's what you had said. But it didn't really get an answer then, to be perfectly honest. And instead, the answer fed around. They will be benchmarking around theatre optimisation, ensuring that you can change the culture for better improvements, and also they will be looking towards the blueprint framework, which is we expect in June at some time. I asked them if they had engaged with the Royal College of Surgeons with regards to the reconfiguration in this blueprint framework. So I'm asking you today whether, it sounds like you work on the ground, you know what efficiencies could actually be made in order to run the service more effectively. So what engagement have you had with the SPPG and the department, to ensure that there is that work hand in hand?
I suppose to answer the question quickly and succinctly, it's in terms of the blueprint and the template we've not been engaged with.
Not been engaged
No.
with at all? Okay.
No.
I mean, I think that's, perfectly honest, is disgraceful.
No. We do sort of meet regularly with the department, and but in terms of that specific work stream, no, we've not been engaged with.
Okay. Well, I think that's something that we can certainly follow up with as a committee. It is shocking to listen to the experts and the people who are actually carrying out the work. And then on that, then what efficiencies do you see could make use of the elective hubs more in terms of optimising that theatre space? Because unless we build more theatres, we're not going to get more theatre space. But is it being used at the minute we're to its maximum?
No, it's not. And again, it's back to what we were talking earlier, Linda, about workforce. They have the two of them, and only one is commissioned, i.e. they only have the funding and staffing for one of them. So you may have the infrastructure, but you don't have the other components around it.
And I'm sure in the staff, when you staff elective hubs, the staff comes, so if you're doing, the elective hubs and you're doing the same type of surgery for, so many days in a row, 7 a day or whatever, that's the same staff that come with it to kind of ring fence would that get through more and more surgeries to drag down to work through a specific waiting list? Would that optimise efficiencies, or is it kind of a bit more complicated than that? I'm sure that it is more complicated, but is there ways in which they are doing that currently?
I think a lot of the staff, though, appointed to those units work there independently, and that is something that we have seen demonstrated through surgical hubs and the elective care centres around the rest of the UK, is that those staff are not coming from other areas. You're not robbing Peter to pay Paul. What you're doing is you're saying that they are selected to be there, and to be there the 5, 6, 7 days a week, and that is their role, to be there. It is not to sort of when they get free or freed up from something else.
And that's for all of the staff, including surgeons?
Not for surgeons.
Well, for
no.
surgeons, but that's what I'm asking, for surgeons specifically, for surgeries, in terms to making it most effective.
No, the surgeons will work, be primarily based somewhere else, and will travel to there to do it.
And is it working most efficiently now for surgeons to maximise that work?
In general, yes, it is. But again, it's, there could be more capacity built in there to develop those. I mean, in terms of our surgical workforce in Northern Ireland, there's absolutely no issue with surgeons travelling. Surgeons are more than happy to travel and go to different bases and work in different bases. I mean, that would be pretty routine across the water, that you might work in 3-4 different places.
Well, that's very helpful, thank you, and we will certainly follow up as a committee. You don't cover paediatric surgery, in terms of, like you mentioned there, Niall, with regards to kind of regional work versus local work, like protecting your specialties at the Royal, for example, so that unscheduled care doesn't bump it, but in terms of paediatric surgery, how do we protect paediatric surgery in a place where, you know, the children's hospital is not a regionally funded or regionally managed, but is a local unit, but is a regional A&E. It is a regional service, but it's not managed nor funded in that way, in terms of how it's commissioned. So how do we protect paediatric surgery? How do we do it? How do we do it for that?
Well, like all the surgical specialties, I mean, paediatric surgery is the same. I mean, we're looking at somewhere around 7,000 children on waiting lists at present. The current model that they have is that they would like to have the equivalent of you know, an elective overnight stay centre where they can manage paediatrics as well. At present, what they are doing is some of those surgeons are going out to some of our district general hospitals and delivering some of that surgery that ordinarily might have been done there before it sort of went back into Belfast and then it's been moved out again.
Thank you.
I have Deanna just remind members, because we technically only have about 15 minutes left of this section, and I've still got 1, 2, 3, 4, 5 people indicating they want to question, so just to be conscious of that as well. Diane, thank you.
Thank you, and apologies for not being there's a good person with you today. I've a couple of, well, 2 or 3 questions really. But following on from the questions that Nuala was asking about capacity, you mentioned over and over again in your presentation and in your report access to theatres. Now I know that in Antrim Hospital over the weekend, by Monday morning, there were over 60 people waiting in beds. And as far as I'm aware, elective surgery was then cancelled. Is this a situation that you experience repeatedly? Because if that is the situation that you experience repeatedly, we certainly will have real difficulties in clearing any waiting lists.
It is something that we face regularly, and again, I suppose to come back to the point and the issue around what we've been talking about is people waiting. Is we do see that when people have been waiting for a period of time, they actually end up presenting to emergency departments. Yeah. The condition has moved on, and they've now gone from being an elective patient to being a semi-elective to emergency patient. We run what is called CPOD theatres, which are the emergency theatres. They run 24 hours a day, and they are constantly filled. And what that means is that when they run like that, it does bring staff in from other places, and you do end up having to cancel elective lists. Again, why? Because on most of the occasions, the beds are taken up. Again, we're back to the elective work is not ring-fenced from the non-scheduled work. So when non-scheduled work goes up, you have to reduce the elective.
Yeah. Sorry, can I just sort of expand on that again? So a few weeks ago, I asked the Health Minister on a particular date in March, how many beds in Northern Ireland across all trusts were actually blocked is the right word, by people who are ready to go home or, you know, didn't necessarily need a hospital bed. And the answer to that was 600. That's almost the size of a hospital, probably is the size of some hospitals. So it seems to me that there's a whole range of things within the system that need to be fixed to allow you to get ahead with elective and non-elective surgery and to be free to make proper use of theatre time with nurses to do that. And are you saying that only the ring fencing is the issue, or is it the knock-on effect of beds is the issue, or is it the theatre staff that is the issue?
It's a combination of all of the things that we have talked about. Is that we don't have the ring fence beds. Yes, you're quite correct, because of the problems or failures out in terms of community. We are seeing more and more patients staying in hospital for longer, and I'm talking about weeks and weeks that should be out in, care homes, maybe back at home, being able to be managed with visits and stuff that way. So they're continuing to use a lot of the beds in hospital that are blocking for those elective admissions. We then also know, so it's the point that we want to be very clear is that there's not just one single area that is the problem that you can say, if we fix this, it will all go smoothly after. There are multiple bottlenecks and hold-ups along the way. It is a combination of all of these things.
Yeah, thank you. On Monday, I had a question to the Health Minister, and he confirmed that within the next couple of weeks that he was going to bring out his plan for the reconfiguration of hospitals. Now, as far as I'm aware, certainly I, as a health committee member, I have no knowledge of what this plan will contain. Has the department sought advice from surgeons as to what this will contain? Because it seems to me that we're heading in a direction where there'll be specialties in some hospitals and people will travel to those specialties. And it seems to me that it would be wise to have consulted the like of yourselves in relation to this.
Unfortunately, when it comes to this blueprint template, we've not been consulted as the Royal College of Surgeons on it.
Okay. So it's coming out in 2 weeks, but you haven't been consulted?
No.
You're saying that clearly?
Yeah.
That's okay. That's very strange. Maybe Chair would take that up as a health committee. And else. So the other thing I was interested in, you mentioned in your presentation that you had one robotic system in one speciality and one trust in Northern Ireland. Can you tell us what that is? And I'm sure you're going to say funding, but what's the barriers to having more of this, and what's the advantages or disadvantages to having it?
So thank you, Dan, for the question. So it's into urology surgery within the Belfast Trust, and it usually performs 2 procedures, which is partial nephrectomy and prostatectomy. And in relation to the specifics of that system, I can't answer in regards as to how that's used, etc. But in regards to the highlighting that within the statement made earlier, is that robotic surgery is being used and translated into multiple specialties across the globe, but particularly now in the UK, and is seen as a future technology that will be applicable to complex surgical care. Yes, there is an initial capital investment, but there is other similar regions where lessons can be learnt, but obviously that does come with capital investment. But that does attract the global workforce of future surgeons to specific regions in order to use that technology. The evidence in terms of its benefit for patients is still growing, but obviously it was similar to the introduction of laparoscopic surgery and is viewed as to be something that's important to the future delivery of care in surgery.
So you're saying to me that if we had more of this, we would attract more surgeons, we would have more specialities, and would we have better outcomes?
You're quite right. Yeah, there is one system in Northern Ireland at the minute based at the City Hospital, and it is used solely by the urologists at present. There are advanced sort of steps in changing that at the minute, with the potential that a second system will be in place, all being well, by hopefully the end of the year. The specialties that can utilise it are massive. I mean, it can be used by thoracic surgery, it can be used by gynae, colorectal, all of these other disciplines as well. It is seen as almost the standard of care in a lot of places around the UK and around the world, but we are very restricted on our access to it at the minute. Part of that is down to the actual capital investment in it. I mean, the machine itself costs, I think, £2 million, the consumables about it. What you've got to understand as well is that you've actually got to train surgeons on it, because it is a different way of operating. Within my own specialty, we appointed somebody who's robotically trained last summer, and we're still struggling to get them access to that.
Okay. Can I just ask one last question? It's really about Encompass. Can you give us one practical example of where Encompass has caused problems so far in the South Eastern Trust?
Well, one very specific example is the timings of the length of time it takes to conduct a consultation, and the length of time it takes, in my own specialty, this is anecdotal, the length of time it takes to complete a consultation and the length of time it takes to complete a simple procedure like a biopsy. One of my head and neck oncology colleagues has timed himself and finds that it adds 13 minutes to his consultation. And we have been rejigging our timings for local anaesthetic clinics, and we're adding an extra 15 minutes to a previous 30-minute biopsy slot. Because, now granted we're only a few months in, but that is where we currently stand in terms of the black and white of Encompass.
Thank you.
I have Danny, and just before I take Danny in, I am very conscious that we are almost out of time, and I don't want to prevent anyone asking questions, but if I could even ask those remaining members maybe if they are happy to curtail their questions, and then I'll take you first in the next session, because I'm conscious we also have the Royal College of Nurses here, just out of interest of fairness and time.
I'm happy to forgo my question.
Okay, thank you very much, Alan. So I have Danny, Colin, Orlea, and then Alan. Are you okay? Thank you.
I'll be very quick. I'll just ask a couple of questions. First question is, there's two statistics that really jumped out at me there. It was the 66% of surgeons that are burned out, stress and leaving, I think, was what jumped out. And then the 91% 55 to 64-year-olds who plan to retire in the next 4 years. That screams to me as a system in crisis. Certainly I know what it's like for healthcare professionals not to be able to deliver the standard of care that they want to do. I know that's incredibly distressing, and that does lead to, I think you referred to it as moral distress now, and I know that that's right across the board. You know, it's not just within surgeons, it's across medicine and across nursing as well. So basically my first question is just how are surgeons doing? You know, that's just to allude into what you had said there. Second, I know we had talked about would money help here. You talked about it being a capacity issue, capacity as a workforce issue. We do have a workforce crisis right across the whole health service. You know, you'd mentioned in nurses, a shortage of nurses. I think we're about 1,700 nurses short in Northern Ireland at the minute. That's bound to be impacting your ability to increase the capacity. So if money can help, where does the money go to help increase that capacity effectively? And my last one, just to build on Encompass. We've had several reports that have had no south and eastern results because of the rollout of Encompass. So it seems to be that there's no data coming from the South and Eastern Trust from Encompass. Is that going to increase as we move on throughout further rollouts? Are you able to get data out of it, Encompass? Is Encompass able to provide data so that we can see trends, improvements or deteriorations? Is that going to be an issue as we roll out? Certainly, you know, you need to be able to monitor how things are improving or deteriorating. Are we looking at a period where the data available will be declining?
Well, I can probably, I'll take that question if it's okay. What's happening at the moment is the data is building within Encompass in the South Eastern Trust, but the data that previously was being fed into NIECR is not being made available. So we have growing data on Encompass, we have growing oversight of our practice, but we're no longer contributing data to where we previously were. So I would expect that as more trusts come onto Encompass, that the data will improve rather than deteriorate. But we are at an inflection point where at the moment we are working electronic to paper, and because Encompass is taking the data, it's not going elsewhere.
Is that data retrievable?
It is retrievable. Yes, it is retrievable, and some of it is also retrievable by individual clinicians to a greater extent than previously. So the data is there and it will grow, but the NIECR Encompass interface is an answer to the question you've raised at the moment, which is why the data is not coming out. It's just not coming out into one portal.
So that will improve?
It should improve.
It will improve. Okay. And when Belfast goes live, will we have data available from Belfast or will we not?
I think the issue certainly has been with South Eastern Trust is that they have been so focused on actually implementing and delivering the system that some other things maybe have just not run as smoothly, shall we say, but that data will be there. One of the hopeful things of having an electronic care record is that you will be able to marry up things. So you will be able to find out is where a patient is on a waiting list, who's on the waiting list, what waiting lists are they actually on? Are they on an outpatient waiting list? Are they on a diagnostic waiting list? Are they for treatment? So I think down the line it will be very useful to produce that stuff, to be able to, to marry up and trace a patient, because at the minute that is difficult using the current, electronic care record that we have and various other electronic systems that the data is on. So I think, yes, there will be issues at the minute. However, down the line, there are the benefits to that. In terms of answer your other first two questions, I suppose very quickly, yes, the 91% that you talk about, that's quite unique to Northern Ireland. That is not replicated around the rest of the UK. We are stand out in the fact that our senior surgeons, 55 to 64, are contemplating going in the next 4 years. Okay, totally different to the rest of the UK. And a lot of that is down to the pressures. That's, in terms of pressures both at work, not getting into operating theatres, increased managerial responsibilities with a reduction in clinical output. But it's also because it's very difficult to see patients at clinics and say, I know I can do something to make your life better, but I'm going to put you on a waiting list where you will remain for years.
We clearly have a two-tier system in Northern Ireland now. I know a lot of constituents who have had to go the private route, and they're spending huge amounts of money, life savings, and we've mentioned it here before, that certainly that appears to be a lot of people's option. They feel forced into it, and it does exist here. No problem. And I think the last question was just about the money going into the workforce crisis issue. Where does that go if we're trying to build capacity?
Well, I suppose it's been able to maintain a workforce here. I mean, what we would talk about is recruitment, retention, and retirements. So, retirement has changed. That's part of probably Westminster and stuff around retirements and changes and things like this. But it's we do face a difficult situation in that doctors in Northern Ireland are paid less than their counterparts in England, Scotland, and Wales. They are paid significantly less than those in the Republic of Ireland. So we are in that pincer movement between two areas that we don't fare very well.
Colin?
Thank you, Chair, and thank you for your presentation today. If there's three things I think that we should take away from your presentation today, it should be those three letters, SOS, that you said at the start. And I think that if you're issuing this red flag warning about the system, if that has not been heard exceptionally clear in Castle Buildings, then we're in real danger. In the last 7 days, just ourselves as a committee, we've heard from yourselves, the Royal College of GPs, the British Medical Association GPs Committee. We had an event with the Royal College of Paediatricians and Child Health. We're about to hear from the RCN, and the message is the same time and time again. It's not that we're heading to a crisis, we're in a crisis. You had said earlier that if all theatres were going full kilter 24 hours a day, 7 days a week, 365 days a year, it would take 3 years to clear the list. Many parts of these islands, a wait of 3 years would be considered ridiculous. And that's what we're expecting our population to have to deal with if it was going all the time. And it's not. People are going on lists that are going to take 10 years. And I suppose if we're hearing that information and we can take that interpretation clearly, can I ask you, are the department listening to you? Do you feel that they actually hear what you're saying, that they understand what you're saying, and do you feel that they get the concept that there is a crisis that we're actually in at the minute, not something that is coming down the line? Are they hearing your cry of SOS?
I think it's fair to say, yes, the department does listen and they do understand. But, let's be honest, we're not just facing crisis within our healthcare service at the minute. We look at schools, we look at everything. It's everywhere, We are in a very difficult fiscal time at the minute. And yes, let's be honest, a lot of this is carry over decades and stuff. We weren't making hay whilst the sun shine. We're now in a difficult situation we don't by any means turn around and say, well, look, you need to give us the £1 billion that we talk about. We need it next week and do it. We understand that there is responsibility in terms of delivering money for infrastructure, for, as I say, the schools, for healthcare as well. But we are in a major crisis in healthcare, and healthcare is about people and individuals. And if we don't address that, we really are letting our population down.
You're in like surgical experts. Are people dying because they're on a list? Because of being on the list, not while they're on the list, but because they're on the list?
I could tell you yes, because we know that when people wait, they deteriorate, their conditions get worse, and unfortunately they do. I know of an issue at one stage where the mortality on a waiting list was higher than the mortality of the operation. So people are dying on waiting lists, yes.
If we have a healthcare system that's killing people rather than fixing people, we are in a desperate situation. But thank you for detailing.
Thank you. And finally, Alan Chambers.
Yep, just a quick question. You talked there about patients on a waiting list and they've got a disease and they're going to have to wait 5, 6, 7, 8 years to actually be operated on, and that disease is going to get worse. A cohort that we maybe haven't talked about, maybe I should declare an interest here, and that is elderly patients. If they've got a condition that's maybe not a disease, but just a condition that's not going to get any worse, but they're getting older and they may have to wait 5 or 6 years, so they've aged before they get into the operating theatre. Does the risks of that surgery increase with age?
Yes, it does. And that's, I think we've talked about that, as the fact is that what we call the morbidity, so that's the adverse outcomes of the operation. So not that you might demise from the operation, but complications that you might get increase the longer you've been waiting, increase the older you become as well. And as we talked about, it makes the operation more complicated. That means you're under anaesthetic, means you're in an operating time longer. That increases the risks of the operation as well. So we come back to this. Delays delays are not just it's taking a little bit longer to get your operation done. A delay means there's increased costs, both financially, there's increased cost to the patient, and there's just an increased cost to the general population of these people who are waiting, being removed. These are your, okay, we'll talk about the elderly. These are the grandparents that can't go out and play with the grandchildren, can't lift them, can't go to the park with them because they've got problems with hips, knees, various other problems. We are talking about this. Disease is dis-ease. People are not at ease.
Thank you. Thank you, Chair.
Thank you. Thank you all. I think that was definitely a very, very important discussion, and it's something we will be taking forward in some of the points that have been raised. And I want to thank the members. Some members then held back on their questions just because we are very stuck for time, and it's not to minimise the importance of this, but as you can see, everybody had quite a lot to ask. So we really appreciate your time and the paper provided, so thank you.
Thank you as well.
Okay.
Thank you.
Members, before we move on to the next briefing, I just was 2 suggestions I was going to make. Obviously, the lack of engagement around the blueprint is very, very concerning, particularly given the date is close for publication. So we'd ask members for agreement that we write to the Minister on why the Royal College of Surgeons hasn't been engaged on the reconfiguration blueprint and who they actually have engaged with. So if members are happy enough for us to do that. And secondly,
Chair,
sorry, Diane.
Could I just ask that we ask for the briefing for the Health Committee as well?
On the paper, yeah, absolutely.
Yep.
Yeah.
I'm glad that there's work being done on it, but I was surprised that it was coming out, and I asked some of my executive colleagues, and they didn't know anything much about it either.
Yeah, no, it's news to me as well. So yeah, no, I think that's fair enough, Diane. The other point I was going to raise is around using, in terms of the resource used, and I raised the issue around scanning and diagnostics. And as Ian had mentioned there, that it's only a 9 to 5 service Monday to Friday. So could we write to the department or the Minister to ask what consideration they're given to expanding that service so that people are being seen quicker, particularly around with red flags obviously, but urgent cases I'm told aren't even being looked at in some areas, and for those planned cases, so for people who have a history of cancer or other conditions who require regular scanning and are experiencing significant delays. Okay, thanks, Olivia.
Yeah, and maybe just to add to the letter, if the rest of the committee's content, because it was one of the questions I was going to ask, but it was the points that Colin was making there at the end, that 91% of, obviously the majority of surgeons talking about leaving or retiring within the next 4 years. I mean, if they're saying a crisis point, that does sound like a pretty big crisis, you know, and even the impact it's going to have on then the trainee surgeons. So could we just fact that I was going to ask if they have actually approached the minister to give them that really stark stat around surgeons thinking about retiring. So if we could add that in to ask for the minister's response on that, would be helpful.
Yeah. Sorry, Alan.
That's exactly my focus, Chair. I mean, that figure, 91%, is very stark, but it's a fact that is a cohort and a particular age group that has a huge experienced skill set that is going to be lost in the next few years.
Yep. And it'll lead into some of the discussion I'm going to have in the next session as well around that mix of experience and all of that as well. Okay, members, thank you. Thank you for that. I'll now move on to our next briefing, which is the Royal College of Nursing, who are going to provide a briefing on workforce, and refer members to tab 7, page 61 of your pack. Again, members, we're very, very tight for time, so I will keep my own questions as brief as possible as well. But if we can keep to that during the course of the discussion, I really appreciate it, because we have some SORs to get to at the end, and we need to keep a quorum. So just to thank you all for attending, and apologies for the delay, we appreciate your patience. So in attendance today we have Breach Quinn, who is the chairperson of RCN, Rita Devlin, Executive Director, Dolores McCormick, Associate Director for Employment Relations and Member Services, and Ruth Thompson, Assistant Director of Nursing Policy and Practice. You're all very welcome. We really appreciate your time. So with that, we'll open up to yourselves.
Okay, thanks very much. So just want to thank you all for the opportunity to present our analysis and commentary on the current issues facing the nursing workforce in Northern Ireland. You will have already received our written briefing, which I hope that you found helpful, and that's alongside our recent letter to the Health Minister, copied to yourselves, setting out the current priorities on safe staff and pay and patient safety. I'm not going to repeat what we said in the briefing, but we're very happy to respond to it should you have any questions on the themes that we have outlined. As you've said, while we were in the room, every organisation that has appeared before your committee during this current mandate has referenced the escalating crisis within health and social care, and we aren't any different in that respect. However, in our brief introductory remarks, we just want to highlight some of what we feel are the underlying causes of the position that we find ourselves in, but also we need, more importantly, to try to identify areas that give some grounds for optimism and a sense that the crisis is neither inevitable or irreversible. Here in Northern Ireland, we have nursing workforce shortages in all areas of practice, which significantly affect patient outcomes and staff productivity. The key underlying reason, we believe, is that we simply don't have enough staff to deliver safe and effective patient care within the context of a health and social care system that was already overstretched after years of underfunding and political inertia. So we need simultaneously to tackle the workforce crisis and make sure that nursing is and remains an attractive, well-paid and meaningful supported profession. So our written briefing summarises the range of measures to promote the delivery of safe and effective care, and more appropriately to recognise and reward the contribution of nursing staff. These measures would help us to move in the right direction, and I'm sure the committee will want to discuss some of these issues with us today. It is, however, important to understand that we have somehow managed to create a system now in which financial priorities are taking precedence over professional concerns, and we are very concerned about that. We know good care costs, but poor care costs even more. Nursing is a safety-critical profession. It's focused upon the reduction and prevention of harm to patients. This, in the long run, in the long term create savings through reducing length of stay, reducing readmission rates, as well as mitigating clinical negligence payments, which are huge in Northern Ireland. However, the current short-term approach to health service funding and strategy doesn't support this ambition. The Minister, the Department of Health Officials and almost every organisation that has appeared before this committee has highlighted the need for substantial and sustainable multi-year funding in order to bring about the transformation of our health and social care in Northern Ireland. We desperately need to move away from the short-term sticking plaster approach, and we need to focus not just on treating the manifestations of ill health, but on tackling their social determinants. We need to embed the Marmot approach to addressing health inequalities by creating the conditions for people to take control of their own lives. This requires action across the social determinants of health and beyond the sole reach of the health and social care. This in turn means returning to the original ethos of transformation, prevention, early intervention, keeping people out of hospital where clinically appropriate, and creating alternative sources of access to the system, particularly in relation to our community and domiciliary care services. It requires investment in the specialist community nursing staff who can deliver this vision, district nurses, school nurses, health visitors, community psychiatric nurses. It also requires a focus on how we can take health and social care services directly into our communities instead of reheating tired and tiresome eternal debates about the configuration of acute hospital services. In this respect, I was appalled by the use of language in recent newspaper reports on an assembly question. The newspaper report referred to people awaiting hospital discharges as bed blockers, a term I had hoped had been eradicated from our language. It's dehumanising, insulting and inaccurate, and it creates the impression that the lack of bed capacity in our acute hospitals is somehow the fault of patients, rather than attributable to a service, particularly in community and domiciliary care services, that is broken. The same people who use this demeaning term routinely refer to non-clinical health staff as pen pushers. This type of language is disgraceful and needs to be eradicated. The RCN believe that the escalating crisis within the health and social care system in Northern Ireland represents the culmination of 14 years of prioritising short-term financial expediency at the expense of patient safety and quality of care. The inquiry into events in Mid-Staff's NHS Foundation Trust showed us all what happens when financial issues are prioritised ahead of patient safety and quality of care. And I just want to share one extract from the inquiry report, which I believe remains universally valid. It stated, "A shared positive safety culture requires shared values in which the patient is the priority of everything done, zero tolerance of substandard care, empowering frontline staff with the responsibility and freedom to deliver safe care, recognising them for their contribution, and that professional responsibility is accepted and perused." 11 years later, this message remains as powerful as ever. We urge the committee in the exercise of their scrutiny function to decide what type of health and social care we are seeking to promote and help develop. Committee members are, we believe, uniquely well placed to question and challenge policies, strategies and attitudes that do not put the patient at the heart of the system. We believe there's a strong consensus throughout the health and social care sector that will support and work with the committee in the exercise of this strategic ambition. We must find ways to bring hope into the picture, hope that things can get better, and hope that we are fully committed to making things better. The RCN believes there are a few things that can be done to engender this feeling of hope and a feeling of being valued within the nursing community. We need to start listening to frontline staff when it comes to trying to transform and modernise our health and social care services. Our nurses know what works and what doesn't, but they are often not engaged in the discussions around transformation. They are desperate to make their health service function properly. Leaders and policymakers must start listening to them. We ask our members what would encourage them to stay in the health service because, as you know, we have an exodus of staff as well. And it's very simple. Fair pay, along with recognition that nurses are working far beyond their band. We need a career framework to be reviewed and nurses to be recognised for the work they do. We need better treatment by managers and employers across the HSC and the independent sector, and flexible working to enable them to have a proper work-life balance. We need to be solution focused, and we need strong lines of accountability and communication across the system, as well as clarity about where decisions are made, by whom and upon what basis. While this briefing accompanying oral evidence has focused on the challenges the RCN believes need to be resolved, it is important to remember we have a world-class nursing workforce here in Northern Ireland. And I know because I work in an area that's for country. We have highly talented, highly educated and deeply committed staff delivering often in the most difficult circumstances, high quality and safety critical nursing care. And they look after some of the most vulnerable people in our society. This is emphasised once again through the nominations we have received for our annual RCN Nurse of the Year Awards, recognising, supporting and appropriately rewarding our brilliant nursing staff, whether they practice in the HSC or nursing homes, GP surgeries or primary care settings, would make an invaluable contribution to addressing the crisis within health and social care in Northern Ireland. I'd just like to finish by asking the committee a simple thing. Be more ambitious for our people. Be courageous in your leadership. Look wider than the Health Service for health improvements. Deliver a programme of government where in every aspect of spending, better health is the expected outcome, and deliver a fair society for everyone. Thank you for listening, and we're very happy now to take any questions.
Thank you, Rita, for your remarks, and I think across the board here, it'd be safe to say that everything you've said we would be more than happy to get behind. We know huge challenges across nursing in particular, and I suppose particularly around the fact that 51% I think of your workforce is on a band 5 pay grade, but are delivering way more than that. And I suppose just from my own perspective, from working in health and social care, it always amazed me, and I think I've said this to you before, that when I started out my social work journey and it was at the bottom of a band 6, I was going into work alongside very, very experienced district nurses who were on band 5, who were hugely important to support me in my role. And I just wanted to make a point on that, because I think that can reflect some of the disparities that you have alluded to in your introduction. And I suppose that would lead into some of what the questions I'm going to ask. You mentioned around the safe staffing legislation, and yesterday I met with BASWA, the British Association for Social Workers, and they too have been emphasising the need for us to see this being brought forward. So just it's something I think that particularly maybe as a committee that we would need to get an update on to see where that's at, because it's hugely important. What I said to them when I said to you now is it's very, very important, but that will take time and we need to do more now. So that's not going, we need to be seeing some action here now to protect nurses in their roles, but also to protect patients, because currently the way things are operating, it's clear that it is unsafe. Going, I suppose, into the workforce issues that you've outlined, and your briefing paper was very, very helpful, so thank you for that. It's very detailed, and it's certainly for myself helped ahead of today's meeting. One of the biggest issues we've been hearing time and time again, and you've outlined the reasons for it, is those newly qualified nurses. They're trained and then we lose them. How big can you give me a wee bit more detail on the scale of that problem? I know certainly whenever I was going to decide where I wanted to study or what I wanted to do, nursing was the top priority for many of my friends. But now we're seeing that it's becoming a lower priority for all the reasons you've outlined. So for those who do decide to go down that career route, what is the scale of in terms of the numbers coming out of university and where they're going?
Well, that isn't tracked actually by the department, so we don't actually know where we know where they may go initially, and our worry is that we're losing them in year 2.
Yeah.
So they're staying and getting maybe a year's experience. They're maybe working to agency for a year and then they're heading off to Australia, Canada, America, places where they actually feel valued and they are paid probably twice as much. And one of the things we're quite concerned about is we have recently learned that so we work for we register with the Nursing and Midwifery Council in the south of Ireland. It's the Irish Nursing and Midwifery Board. And we have heard recently that they're looking to have a quick turnaround for registering NMC nurses onto their register, which is attracting some of our students. at the minute, because some of our students are being told there are no jobs for them come September.
Yeah, and I suppose on that note, I know prior to during the period the Assembly was down, I've been contacted by some nurses who've been working a long time in the north, who have been trying to transition over, and were contacting my office for support to try and get onto the register. So that was telling me, and I'm thinking we don't want you to go, but you can understand why
Our border
do go.
counties are very vulnerable now to losing staff.
Yeah, no, and that's something we have to be very cognizant of, and how we try and mitigate against that. Going back to the point, and we talked about it briefly in the last briefing, around that importance of the mix of expertise and experience and people who've been there, and we are seeing people retiring earlier. How much of an issue is that across nursing and midwifery? And the reason I ask that, I know maybe you can't answer because obviously with the representatives for midwives as well, but I have been dealing with in the last 18 months a cohort of midwives who have retired but are obviously going back in, and we have been doing some work on legislation through the committee in relation to some of that. But in terms of in relation to the terms and conditions that are offered to them, I'm fine. The issue that I find is that it's actually putting people off wanting to stay in the workforce on their terms, but we know the value of that.
Yes.
So I've probably asked a couple of questions in one there, but you get.
So there is a retire and return policy. How it's implemented, it seems to be different in different trusts. So, for example, some people can retire and return on their own grade, and other people have to retire and return on a band 5. So again, there's no it doesn't appear to be there's regulation around it, and the trusts are doing whatever they have to do, I think, to get staff. So if you were working in an area, for example, where you were very expert, you would probably be allowed to retire and return on your band, your higher band. But if it was just a general, seen as a general post, you might have to come back as a band 5. So.
Okay, and it's only just because when we're seeing the huge issues in workforce, and we have a workforce cohort who are readily available, will be able to slot in where needed, have the expertise, the experience, and we don't want to be putting barriers in place to be able to access that. The only other question then I wanted to raise is because it's been quite an issue we've been dealing with this week in the Assembly Chamber, is on the hospital car parking charges. And I know in during the period of the legislation coming through, the RCN were very supportive of that. And as I said, there are 51% of your workforce are band 5 nurses. And I said this in my contribution to the Chamber this week. What sort of impact does that have on a nurse on a band 5 wage, who potentially, as I had mentioned, has maybe childcare costs, or working maybe 5 days a week in a hospital, long shifts? What sort of an impact does that have of having to foot that bill?
I'll let Dolores answer that one.
Okay, thank you for that question. You're absolutely right. The RCN did support the car parking bill as it went through, and I did give evidence at the then Health Committee around that on behalf of our members. So at that time, many of our members, and as you say, on a band 5, predominantly female profession, childcare responsibilities, having difficulty accessing car parking and then having to pay sometimes up to £11 a day, it had a considerable impact. And absolutely there was a piece of work undertaken during the last Assembly where we looked at the recruitment and retention of nurses, and one of the big things that did come out in that in terms of a blocker for our members was car parking charges. That definitely was an absolute disadvantage. The other thing we must remember is, due to the caring responsibilities that many of our nurses have, they're dropping children off, they're dropping them to school, or they're dropping them very early for early shifts. So having a car park close to work is absolutely essential. So they don't have the same luxury as someone working a 9 to 5. Where they can access public transport. It's just not as feasible for many nurses who work shifts.
Okay, no, thank you.
And also travelling huge distances to come to work.
So I suppose we're absolutely appalled that this has been pushed back for another 2 years. We supported the bill, and our members are also extremely disappointed.
Okay, and I suppose just to say on that, there was some discussion, and the Minister said he is working towards a permanent for people who are, I suppose, like you said, Rita, living furthest away, and the department are working through some of that. But from the outset, we are certainly very disappointed that this is still at that stage. So hopefully we can get that resolved as quickly as possible moving forward. So I'm going to move on to members. I have Colin.
Thank you, Chair. I suppose maybe I wanted to just ask you about the impact of the lack of safe staffing legislation. We have determined from the Minister in his legislative programme when we asked about it that it'll be at least into next year before that safe staffing legislation is progressed, and obviously there will then be a lead-in time before that is actually delivered. So I was wondering if you could give us a sense of what the impact of not having that legislation and what impact that has have on your members.
I suppose for us the whole idea of the legislation is about identifying who is accountable and responsible for what. So legislation in itself is not going to give us more nurses, but what legislation needs to do is we need to understand who is accountable for the commissioning of the places, for the nurses to be trained, so therefore we have enough supply. And at this point in time, there doesn't seem to be anybody taking responsibility for that. So at this point in time, we commission what we can afford rather than what we need. And year on year, that has an issue then for us in terms of the growth of demand within the health service is huge, as we know. And we are being told, yes, there has been a growth in nursing, in nursing on the on the employment of HSE. However, it in no way meets the growth of demand, and in some cases we have had actually a reduction. The learning disability workforce has reduced by 30%, and in mental health, it is basically has stood still. It hasn't grown at all, despite what we know in terms of the growth of need for mental health nurses. So legislation in itself is about us being able to hold people accountable for responsibility. So Department of Health responsible for commissioning, the Trust responsible for having enough staff to deliver the care based on what is identified as being safe. Within Northern Ireland we have our own Deliver and Care framework, which is a policy framework at the minute. So that identifies for us how many nurses we believe we need to deliver safe care. One of the issues as well that we have is so if you run a ward, for example, you have a funded establishment. So if you have a 30-bedded ward, you'll have a funded establishment for a 30-bedded ward. Most of our wards now have 3, 4 and 5 extra beds with no extra staff. So we basically are looking after 35 patients with a staff and cohort of for 30. And within our A&E corridors, we're looking after probably 2 extra medical wards every day that aren't staffed. So staffing in itself, workforce figures in itself, what you're being told by the Department of Health is about what is being recruited to, and what's being recruited to is usually funded establishment. Funded establishment is not what we need because we're way over, our bed usage is way over what was ever funded for. And the people who obviously pay the price for that are the patients, but also the nurses who are trying to look after them and do the job of 2 people sometimes. And that, it used to be that when we had an extra bed, it was a crisis escalation bed, and it went up and it came down. Those are now counted as part of the ward. They don't ever go down. So we have a situation where we are way under what we would consider to be safe.
It doesn't take a genius, which makes it easier for me to understand that if you've got more patients to look after, that puts more pressure, more stress on the staff, and it also then could inevitably lead to care issues, which is unfair if they're being put under the extra pressure for it.
It's not safe.
Yeah, and as you mentioned as well about the learning disability nurses, you have 36,000 people in the north with a learning disability, given a ratio of 1 to 83 in terms of the nurses that's there. I mean, that's again putting huge pressures on them in a sector with some of the most vulnerable in our community. So I think some safe staffing legislation coming much sooner, putting those figures, putting those boundaries down, and then allowing staff and patients to operate within those boundaries is critical.
I mean, I know it's said all the time, but you certainly wouldn't get on a plane where it didn't have enough staff to well, you wouldn't be allowed. You wouldn't be allowed to get on a plane where you didn't have enough staff. But you're allowed to go into a ward where you don't have enough staff. And some wards we're having maybe 1 or 2 registered nurses looking after 35 patients. It is not safe.
Fair flan, I'm getting on a plane tomorrow, thank you. But I'll pass back to her, thank you.
Just before I take note on the basis of that, Rita, maybe it's not something that you can answer today, but see where that is happening. Are we seeing an increase in incidents or SAIs? Yeah.
So the things that you will start to see are an increase in pressure sores. There was something about it was last week, was it? We were told about somebody. Somebody was taught. So increase in pressure sores, increase in medication errors, increase in falls, increase in length of stay, because patients aren't getting the care or treatment that they need. So the increase in length of stay obviously has an increase on flow. So everything gets backed up. There's no efficiency in the system because it's just everything's just overcrowded. People are stressed. Things are being missed. People are being cared for in areas that should never be cared for. Corridors, sluices. In the paper last week, wasn't it? In Altnagalvin, it was
locker room or
staff locker. Those. If we had. Those are things we would never have envisaged years ago.
No.
Never.
And just my last point on that then is where there's things, medication errors and, increase. If a family then make a complaint, or where does the blame go?
So if you think about it, harm is always caused to somebody at the level of the frontline staff.
Yeah.
So it will be the nurse who gives the wrong medication or omits the medication or does the wrong thing. Those will be the people that will be held accountable. But they're being asked to work in a system that is unworkable, and the system does not support safety. And nursing is a safety critical. So the surgeons do the work, very complex work, and the patients come out onto the wards and the nurses look after the patients and they highlight any changes, anything. So they should be there quickly to do observations, to check the patient, make sure the patient's okay, to make sure they get food, nourishment, hydration, because the wound won't heal if you don't get all that. So we constantly are spending money in the wrong place, and we're penny wise and pound foolish, because we keep having to pay for the mistakes that are being made because we are not investing in the services and the people that would keep us safe in the first place.
Yeah, and why would anyone want to go into a job where they're maybe at high risk of being the subject of an investigation for the reasons you've outlined?
They end up in front of the nurse and midwifery regulator. But worse than that, if you cause harm to a patient, you don't ever forget that.
Yeah.
Mm-hmm. So even if somebody was to say, if a patient comes to harm on your watch, it's not something you ever forget. You can't go away and say, well, it wasn't me, it was the system. You carry that with you your whole career, your whole life. So it's not just about the complaints and the referrals. It's actually about people having to live with not being able to deliver care that they should have delivered. And they never get over that.
No, absolutely. And I suppose that's what I was alluding to, is the fact is the impact on a nurse or those frontline staff. Yeah. Because that's not what they are out to do. They're out to do their job and they want to do that well. And I think anybody that goes into nursing, it's a vocation. So to try to put people in that position is very, very difficult. And I completely understand why people are leaving on that basis alone. So thank you for that. Sorry, Nuala, thank you for your patience there.
Thank you. Thank you very much for your presentation. It is just fantastic to know that there are so many nurses out there who we know remain in a very caring position and want to do the best that they can. But it is just unfortunate now that the service has just relied on goodwill rather than actually implementing safe staffing or implementing better working conditions, for pay, and I just wanted to remark on the fact that this is my first time at Health Committee, and I was not in MLA but in a different role at Stormont, and back in 2020 I do believe that the nursing strike that took place, and many would agree, was a major factor in getting these institutions back up and running. So do not underestimate the value and also the experience and the worth that you all have and your voices have with regards to influence in the political context as well. So thank you so much for coming today, and I wanted to focus some of my questions around the fact that 90% of your workforce are predominantly female. I also remember when I was a young kid and I was hospitalised so many times, I remember it being fun. I don't remember being in hospital being difficult. I remember it being fun, and it was because of the nursing staff. And my children unfortunately have been in hospital a number of times. They're still just as happy people, but you know, in the front face, you know, when you see them behind the counter and know they're under stress, and it's amazing how they can just snap out of that quickly because no choice. Again, it's about goodwill and they have to. But they also, and 90% of them, they have families at home. You know, they're entitled to maternity, and that leads to my questions. Whenever you do have a workforce that goes on maternity, do you actually have the funds to actually be able to hire and cover 100% of those posts that have gone on maternity?
I'd let Ruth answer that one.
Yeah, not usually. There'd be minimal, probably, allowance for that. And I think it's also something that stops women progressing in their career as well, because if you're in a role then that you're maybe work alone or part of a smaller team then as a specialist, then there's not the same leeway at all. But yeah, I think that's a major factor. So most of our wards will also be down on staff because they can't cover the costs of additional staffing.
I don't understand how that is not discrimination on an entire workforce with regards to gender. Like that just screams it's discrimination to me. That they are entitled to maternity and to go off maternity in the safe knowledge that their colleagues can actually continue on. I suspected that was the case. You know, we hear anecdotally, so wanted to hear from yourselves as well.
I've known of times where not until there's quite a number of maternity leave at the same time, like we're saying 5, 6, 7 of at a time, before there's action taken to think we need to consider how we cover this. So you're right, that has an impact on all of the rest of the staff, but more importantly it has an impact on the patients. And if you're already got a stretched workforce and additional beds, then yeah, it all has an impact.
And you have mentioned, Rita, that legislation, the safe staffing legislation, won't actually provide the additional nursing, but I think it's important in the piece of work there to scope out actually, could it include those responsibilities of, you know, not discriminating, and well, we're supposed to have protections already, but actually ensuring that there is cover in those. So is it something that you as a college have scoped out with regards to the maternity issue?
We have looked at it, and when you do staff and working out staff and numbers, there is what is called headroom. There is a percentage that is allowed for sick leave, annual leave, and study leave, but it means that it's predicated on sick leave being 4%, 6%. In some of our areas, we've 20%, 25% sickness. Sickness absence is huge at the minute. So if you think about your funded establishment is based on a sickness of 4%, you've got 20% plus then maternity leave on top of that. So the whole issue of sickness absence is because you can't pay for somebody twice. So if you've got somebody off sick, you can't replace them because you've already got your funded establishment. So you're expected to just make do and mend. Or if the patients are very ill, you may get agency or bank.
Which undoubtedly costs
it does.
a lot more.
But the whole premise of agency in the past was that it was for a length of time for an emergency sort of situation. Now we can't run our wards without them. And now sometimes people are going in and they're the only member of staff and the rest of the staff are agency and they're only there for the day, don't know the place, don't know the patients. And that's what you're expected to try and deliver safe care in that kind of environment, which is very stressful.
Thank you very much. And just my last question, again I want to thank you for coming today, is just supplementary to what you said. Why are you seeing in terms of 20 to 25% sickness rates?
Huge mental health issues, huge stress, musculoskeletal. What are the other?
Stress, a bit of bullying, harassment, lack of flexibility in terms of off-duty cover, rotas, primarily stress. And what Rita touched on earlier, you know, that an ability to deliver the care that you want. Staff just burn out, yeah.
Go in every day and they feel like they're coming out again, they don't feel like they've done a good enough job. They feel that they've let patients down, they haven't got to do everything they wanted to do, and that's not what any of them come into nursing to do. So to have that day in, day out, and feeling like you've let, even before there's actual harm done, even if you just feel like you haven't done a good enough job, or you haven't been able to provide that vigilance that we would say, you know, where you've given the proper monitoring and you know that all the checks have been done and everybody has had the appropriate care. I think to go in day after day, that certainly reduces your job satisfaction and then increases your stress immensely.
Nuala, if I could just say that we've had nurses tell us that coming to work is like being in a domestic violence relationship. That's what it feels like to them. That they come in every day, get beaten up every day, go home. But they still, I don't know how some of them still keep coming in, but they do. But that's what they've described it like. It's like being in a domestic violence relationship.
Not healthy for anyone. It's not healthy for the system, the patient, and most importantly in that aspect, it's not healthy for the nurse either.
And in the briefing, just in the briefing note, we mentioned the recruitment retention piece of work that was carried out, and that made several recommendations. And you know, as far as the college is concerned, we're really disappointed at the lack, and that's something that the committee could take forward. All of these issues that we've just raised around stress, low morale, burnout, that's nurses' responses to that survey. And it was a Department of Health survey, and recommendations have been made around that, but there has been absolutely no implementation by the employer. So what? Sorry, Brave.
Sorry, I just wanted to add in relation to the violence and aggression against nurses. We all know that nursing is a highly respected profession and the most trusted profession. And we know that members of the general public and their families do not go into a hospital ED or into a mental health ward in order to beat up a nurse or verbally abuse them. So we have to ask why is it happening? And in relation to all of the pressures that are on the workforce, the fact that there isn't enough staff, the fact that there are staffing pressures, the fact that there's overcrowding, the fact that there isn't enough beds, the fact that there's corridor care, all of these become a tinderbox for the outworkings of that, which can be abuse and violence towards nurses. So whilst we want to improve the opportunity for employers to ensure that they are supporting and caring for nurses who are assaulted and traumatised by verbal abuse, we know that is only half the issue. We have to get to the source of the problem, and we've been talking about the source of the problem here today. So if we address one, we can solve the other. And I think it's important that we understand the connection between our workforce issues, our staff morale, and also violence and aggression against the health workforce.
Thank you for that, Paige. That's a very important one as well. Danny, and apologies, I had switched you about.
Oh, sorry.
Danny should have been in before you.
No, you're
So
right.
go on ahead, Danny. Sorry.
No problem. Yeah, and actually I think I should declare an interest as a registered and working nurse. I recognise all of those situations and it's horrifying. I recognise violence against nursing staff. I myself have been involved, and I know plenty of other colleagues that have been attacked and have had to take significant time periods off and had significant injuries. It really is, and I understand the situation where you're in a very high pressure situation, you cannot deliver the level of care that you want to, and how that can be frustrating for the nurse. I know nurses that have left the profession because of that, because they simply can't cope with that level of stress of not being able to deliver the level of care that they want. And it can be frustrating for patients and families as well. They feel they're not getting the level of care that they deserve. The whole system you were very clear there, Rita, way under what we consider to be safe. So the system is not safe at the minute. And that came through very, very clearly. I agree, unfunded beds. We've had corridor beds getting worse and worse and worse, and now they're constant. They're part of the furniture. And the nurses on that ward are expected to look after 5, 6 extra patients, and not able to do it when they're short-staffed. It is a horrendous system at the minute, and I hear from colleagues all the time just about their experiences getting worse. Just a couple of questions. There was one thing you mentioned there, Rita, no jobs come September. As I understand it, there's 1,725 vacant posts at the minute.
Yeah.
Why would somebody coming out of university as a nurse feel there's no jobs come September?
Because they're being told that, because financial constraints are being used as decision-making tools.
When we have a huge shortage of nurses, and the surgeons alluded to that being a capacity issue for them as well, there's still no jobs available, no jobs. They're being told, these student nurses are being told.
That's what we've been told, but the student nurses have told us that, and the lecturers at Queen's and University of Ulster have told us that. We have written to the Minister, so I've had discussions with CNO about it, and we've written to the Minister last week, just to be clear that we want those, because obviously if those student nurses think there's no jobs for them, they'll go somewhere else. We'll not get them at all, which be a catastrophe. So we have asked that they are reassured that there will be posts for them. So I mean, I'm not great at maths, but I don't understand how you can have 1,700 plus vacancies and actually tell 700 nurses there's no jobs for them.
That's where my confusion.
So we don't know what's going on there. The health service only recruit to, they only count vacancies as jobs that are being recruited to. So if there's a financial constraint, then they'll put them into scrutiny, or they won't recruit to them. So a vacancy in your ward doesn't necessarily translate to a vacancy that's being recruited to.
The actual number might be higher
than
the 17.
Oh yes, could be higher, yes. So there's no clarity for us around who's making these decisions, where they're coming from, but we are being told that they're looking, and that doesn't even take into account the number of nurses who will be retiring between now and September. So somebody somewhere needs clarity very quickly on that, and that's why we're concerned when we hear. We had some of our judging for Nurse of the Year there. Honestly, you should come to those. They would do your heart good, some of the nurses that we have met. But some of the students were telling us that they'll apply down south because there's a fast track now to get them on the regulator, on the register down there.
That's incredibly shocking.
So if you can do anything about that, I think we really need some clarity around that ASAP, because we will lose those new nurses.
Absolutely, I think that is something possibly we can talk about, writing a letter and finding out what's going on there. One other issue, two other issues. When you raised when a nurse makes a mistake under a pressurised system, and when you're operating constantly and running from patient to patient to patient, you can see how mistakes can be made, medication errors, or you can see how you could forget to turn somebody and a pressure sore could develop, and then the nurse could end up in front of the NMC. Is the pressure on the system a consideration in that investigation? So when a nurse is in front of the NMC, are they saying the system was desperately understaffed, they had far more patients, they had unfunded beds? Is that a consideration in that investigation?
The NMC have said that it'll be taken into account, but that doesn't stop you being in front of the NMC. That doesn't stop you having your professional character assassinated in front of the regulator because you made a mistake. Because fundamentally, if I make a mistake, I'm accountable and responsible as a registrant, and I have to go in front of the NMC to answer my case. And whilst the NMC, and it was the same in COVID, the NMC came out and said, we will take into account if the system, if somebody makes a mistake. But again, even if the NMC say, what are they going to say? Well, no case to answer. But you've still hurt someone, you've still harmed someone. So even if the NMC take it into account, it's very hard to live with.
No, absolutely. And I know nurses have been in that situation and find it very, very hard. The system is unsafe. That's the key thing that we're getting from this today. The nurses are desperately trying to do what they can, and you can understand that at times it will be unable to provide. And nursing is a safety critical career.
So an alert, well-trained nurse is your last point of call for a safe service. And if you don't have that, then you have no safety guarantee at all.
I have one last question. I know you referred to it as, is it tired old conversations about hospital configurations. Just given what we have had from the surgeons earlier on today, have you been consulted about the
Yes, I sit on that hospital reconfiguration group. It is very much focused on surgical. It seems to be very focused on surgical.
Yet they weren't consulted.
So I sit on the group. I think it's the oversight group, and there were some work groups, and I believe there were surgeons in that, but I don't know. I'm not sure. But basically, my challenge to them was they were talking about hospital reconfiguration, and there was not one mention of a nurse in the conversation. It was all about where surgical hubs should be, where, what kind of surgical hubs should be, which hospitals should have what type of surgical hubs. And I'm thinking, where are the nurses going to look after the patients here? So it's a very, I'm not sure that it will do what it says on the tin.
And thank you for your answers. Much appreciated.
Thank you. Linda?
The answers to everything have raised more questions, to be honest. I'm gobsmacked. So we have surgeons who haven't been consulted about the reconfiguration, nurses who are on the oversight group but aren't being mentioned in the reconfiguration. I mean, I definitely think we need to have a conversation with the department about the reconfiguration. And I'm honest to God, I'm baffled, and like yourself, there's lots of things I'm not expert in, but I can read, listen. And read what nurses are saying, what RCN are saying. I can read what the Royal College of Surgeons are saying, and Royal College GPs. So listen to the people that are delivering the job. Yeah. I was really glad that actually in your presentation, Rita, that you had that focus. And I think we do need to focus people, and I keep saying it, on everything is about health.
Yes.
And how do we keep people out of hospitals? How do we keep people out of the health system altogether, actually, just to be honest? So I think that's really important, and we need to keep making that point, and I'm glad to hear the health professionals saying it, because that just proves that we're right. It's not about trying to, put people out of jobs or reduce numbers of nurses. Nurses are saying to us, look after people, don't let them reach that point. You'll be part of that, obviously, of looking after. So I suppose on that, I want to just come back to, just on Danny's point. Again, I can't get my head around that, and I think, Chair, did you say that you're going to, did you say it in response to Danny, are you going to write to the department or on that?
Yeah, but I think, we're going to need around the recruitment.
It's something that's being raised with me in relation to specific by staff, to be honest with you, in relation to specific hospitals, and the knock-on effect then for surgery. So, no surgery can happen, as you're quite clearly saying, no surgery can happen without nursing staff. So it's where there are nursing staff, or where there are places that aren't being recruited to, and what is the knock-on effect then for the waiting list. So I think we definitely need to get an answer to that. I'm really, really concerned about the fact that we're having conversations about extra training places. For what? To train them to go somewhere else? That sounds like a brilliant idea. Just everything we're talking about here today just sounds like money waste and money down the drain. It's actually quite frustrating, to be honest with you. But look, we'll try and get answers and get to the bottom of it. And that's what we're actually here to do. We're trying to find solutions. We want to work with the department to try and get to a better place. So just, I suppose my last question, and probably relates a wee bit to what you've just talked about, the Nurse of the Year awards. So it's where I got my eyes opened around specialist nurses and what nurses are doing, could do if we have more of them. How do we start getting to a better place around that? What do we need to do in terms of, working with the department, lobbying the department around more of that kind of work, more specialist nurses, more investment in training, because we need nurses. Yes, we need nurses on our wards, absolutely all day, every day. But we need to know that we can give those that can and want to do more. And this isn't about replacing what others do. Yep. This isn't about replacing. We don't need to replace doctors or surgeons or anybody else. They have a job to do. But I believe that in the interim, before we have a women's health action plan, because that's not going to happen tomorrow. You know, if we had specialist nurses in that sphere, they could do some outstanding work, because they potentially would have a specialism in order to refer people into the right place. I don't think we can do the get it right first time if we don't have specialists, and some of that includes nurses. How do we
I'll
get
let
to a better
Bridge
place
answer
around
that, because Bridge worked for the Public Health Agency and was involved in commissioning.
Well, I suppose where we're at, Linda, at the moment is that we are finding that there's a reticence now for people to come into the nursing profession. So we actually need to start from our 16-year-olds, our students, and we need to start having helpful conversations with them about what it is nursing is and what you can be as a nurse. Because for some people, they believe when they read the press and listen to the stories on TV that nurses are all band fives, that they're having a hard time. Most of them work in hospitals, and they are leaving in their droves, and that is the message out there in the media. So there is a reluctance for people to join the nursing profession. And we want to be able to show what is possible. And you have said that you have been highly impressed when you've spoken to nurses and have heard nursing journeys in relation to career progression. But career progression is something that we need to really work hard at. So recruitment, retention and career progression all go hand in hand. So the helpful conversations I believe we need with our 16-year-olds are around how to navigate what they see as a complex system if they are interested in nursing. So we need to engage with the trusts, we need to engage with the FE colleges and the schools to look at what the messages are around the roadmap for people coming into nursing and progressing through their nursing journey. Certainly my background is mental health and addictions, and Rita did mention it earlier. Within mental health in particular, there has only been a 2% growth in the workforce in the last 12 years. And I mean that is just shocking when the projected demand this year is 6%. And so we really have real issues within sections of the health service in particular. And I certainly will be, calling for more emphasis on producing more nursing and specialist nurses within mental health. So if we have a lack of growth, we then need to understand the unmet need. And what is that unmet need leading to? And what is it we need nursing to do to ensure that those needs are met in the future? And how can we support nurses to meet that unmet need in the future? So certainly in relation to our students, we need to develop that roadmap. We need to support them. We need to ensure that there's funding to allow them to progress. And we need to understand that nursing just doesn't happen in the Royal Victoria Hospital or Altnagelvin, that nursing is in primary care, nursing is in our prison health, nursing is in our homelessness services where we have inclusion nurses, people that we've been talking to in the last couple of weeks in relation to judging for Nurse of the Year. Nurses that get themselves skilled up and trained to ensure that women in prison are getting their cervical smears. Because if the nurses hadn't trained up, they wouldn't be getting them. I mean, that is a public health issue right there. Nurses who are out working with people in homelessness hostels, ensuring not just that their physical health needs are met, but their mental health needs are met, that they get to hospital appointments, that they get to see their GP, they get to their dentist, that they eat a hot meal. These are the real day and daily pieces of work that nurses are doing, and we need to ensure that people who want to come into nursing understand that all of that is possible for them if we provide the means and the funding for them to do it.
Can I just come in there quickly as well? I think nursing is a solution to a lot of some of the the issues that are out there as well. So you're talking about the specialist and advanced roles as well. I think even in the acute settings, so my background's in cancer nursing. So last year our nurse there, Vicky Burns, you can see how she's involved in a lot of that diagnostic workup and those pathways. And when you look at our waiting lists at the minute and the issues that there are in relation to waiting lists, nurses trained and skilled appropriately can take on a lot of that diagnostic workup, diagnostic tests, even that monitoring and surveillance that somebody mentioned earlier on, that if you're already at risk, it's about monitoring and surveillance and to ensure no secondary disease or relapse as well. It's just as important, and a lot of those patients are being forgotten about. But it does take, it's not just, it's the funding to allow for that training to take place. You just can't grow these nurses overnight. It takes time, but that's why we do need, as Bree said, that planning, and it's about ensuring that everything lines up, so the course is available, you get a place on the education, but that there's roles available for them at the end, and that it all works together, because at the minute that doesn't work so well, and that's what causes some problems. But where it does work well, it's just amazing, and hopefully you will come along to Nurse of the Year and get a wee insight into some of that, because we've really enjoyed the last few weeks hearing again some of the fantastic things that are happening, and the innovation. It goes back to that, ask the people on the front line what can make it better. The nurses see exactly what can make it better, and they create and develop these roles that will make things better, and that's what we need to celebrate and ensure that there's not just one of these people, but that every trust has these posts as well. So.
Rach, can I just finally thank you for raising the issue around the violence against staff, because there's a real focus on higher penalties for those, and you're right, most of these people have addiction and mental health issues, and a lot of nurses don't report it for that very reason, because they care about those people and they understand that it's for all the reasons that you have outlined that they end up in that position. It's frustration, it's that nobody has got to them quick enough to give them medication to settle them, and they're just, they don't even know what they're doing, and nurses then don't report it because for that very reason they know that patient, had they been seen a wee bit quicker, but they're in an A&E where nobody has said this person needs to be seen quicker. So it goes back to the point you've made around the safety. Staff are not safe if people are not being seen in the way in which they should be seen. And if you have one or two nurses covering what essentially should be 4 or 5 nurses, and one of those nurses standing out at the door deciding who comes in which door, it's just...
And I suppose just on the back of Ruth, and I was trying to think of Vicky's name there to write that, because I think that was a brilliant example of how we can be sharing that workload as well. And obviously the vasectomy services being transferred now into primary care, there's lots of things I think we can be doing, and nursing is key in all of it as well. The only other person that's indicated is Alan.
Thanks, Chair. I'll probably just declare an interest of having a very close relative who's a band 7 nurse, so just to get myself right, Chair. I think today again has been another grim day for the Northern Ireland Health Committee. We've heard the stark realities of what is happening within healthcare, and I just want to pick up on a point that Danny was making here. Are the numbers tracked of those nurses who are before the regulatory body?
Yes.
Who they are tracked, and is it broken down by those who have informed the body of the pressure that they were under? And can you reveal those figures?
Well, it's a difficult one, because very few nurses will self-refer unless they come to us first and we'll say you need to go and self-refer. Because if you self-refer and say I've made a mistake or whatever, most nurses are referred to the NMC by their employer when something has gone wrong. We would know the figures for Northern Ireland, maybe not offhand, but we could get them for you. What we are concerned about is the higher level of nurses from the internationally educated nurses have a much higher incidence of being reported to the NMC than our own domestic supply of nurses. And we haven't got to the bottom of that yet, but we do know sometimes they're referred where they probably shouldn't be referred. But if you're referred to the NMC, then there's a whole investigation obviously that has to take place. And one of the things is there's so many referrals to the NMC at the minute that there's a backlog of a couple of years, so we can have nurses suspended, awaiting NMC and being 2 or 3 years waiting to be seen by, to have their cases heard. And we, as the RCN UK-wide, are trying to deal with that because it is not what it should be.
I've had the misfortune over the past year, having had very close family members hospitalised on multiple occasions. And as we speak today, I have another family member who is lying in an A&E and has been for the past 3 days. And I've spent mornings and evenings in that A&E. And it is like an absolute disaster has happened outside. The conveyor belt people that are being put through that system and the mayhem that is happening within those A&Es is startling. And as I say, this is another grim day.
Yeah, and you can imagine trying to keep those patients all safe, because trying to keep track of who needs fluids, who needs their observations done, who needs what, who needs medication, did they get medication, did they not get medication. And those A&E departments were not set up for ward-based patients, but they're now looking after, so the medications aren't there, so you have to go and look for them, you have to find them. Things like patients with Parkinson's disease, for example, if they don't get their medications on time, it has a detrimental impact on their health. We have patients who are falling out of bed because they're not in the right place and they don't have enough supervision, and it is just constantly. I know it is a grim day, I do agree, but I would like to say we feel optimistic in that we believe that we would have some of the answers if people would ask and if people would listen. We don't believe that our health service has to go down this route. But fundamentally, every single person has to be pulling in the same direction, listening to the clinicians, what would work well, supporting us and to make sure, because all of this is about patients. This is not about the nursing profession or the medical profession. This is about how we look after the society, how we look after the people in Northern Ireland from cradle to grave. Last week I've been asked on the media to talk about how we are looking after our older people, and at the same 2 days later how we're looking after our children. And the mark of a society is how you look after your children and your old people, and we're failing on both accounts. So absolutely, this is about, I don't know if any of you are aware of the Marmot principles, but this is about social justice. This is about making sure every single person has access to what they need. So for children, it's education. It's for babies, it's health visitors, it's Sure Start, it's it's not just about hospitals and GP practices. If you don't have good education, if you don't have good housing, if you don't have good infrastructure, if people don't feel safe in their own environments, that's not going to lead to healthy adults. So we are very much around about why Northern Ireland is small enough that we should have a programme of government that allows us to deliver on all of that. Because in the long term, it will save us money. We may have to invest to grow, but in the longer term, if we build healthy societies, it will cost. We can't afford an illness service that we have. We can't afford it. We'll never be able to afford it if we don't do something radical about actually looking at health from a different perspective. Health is not just about hospitals. It's about how we grow a healthy society in mind and in body. And I suppose I would say, if we could do that, I think we are optimistic. We're seeing fabulous nurses coming through, aren't we? We're all on judging panels. We've been nearly in tears at some of the work that is being done, despite really difficult, and the enthusiasm and the joy. So I wouldn't like you to think that it's all doom and gloom within nursing. but it's our job to try to make sure that we look after our nurses to allow them to be those people. So it's our job to try to work with you to create the environment where they can thrive and grow and give back to society and work to the highest level that they can.
And all of that Rita has just exemplified there. There's nurses everywhere there. When you think we have our school nurses, our health visitors, and they've all been cut. So we need to go back to the start, and it's about nurses have solutions for most parts of this. If someone would just talk and listen. I just want to roll back to the whole piece around incidents and risk and appearing in front of the NMC and the team I work with are the team that support our nurses when they need support, when things go wrong. But what we're seeing, and Rita mentioned earlier on about the tissue viability, what we're seeing is there's lots of data and lots of stats, and people fill in what they call SAIs when things go wrong, and the hospitals could paper the walls. But there's nothing being done to correct it, if you know what I mean. So there's paper everywhere, a paper trail, data, but nothing is changing, and there's really not concrete decisions being made around how do we prevent these things from going wrong.
Yeah, no, thank you. And I suppose it's good to hear it end on a relatively positive note, Rita. And Dolores, I think that's a very important point you made. And it's kind of what I was trying to draw out, is that behind all of the other information that we're getting, there's huge risks and implications of those risks, and we have to be taking that on board, particularly around the safe staff and stuff. So I really, really appreciate that. So thank you all. I mean, it's been a very, very important discussion, very, very good discussion. I think it's clear investment is very much needed, but I think there's lots of things that we can do that don't require significant funding, and it's about how we do things. And that's certainly what we would like to take forward, because we know the financial situation we're in. We have to be realistic about that. However, we have to think differently about what we're doing and how we do things, and we've talked about some of the really good examples of that. So thank you for your time today. And there's things that we will be asking and taking forward with the Minister and the Department to come out of that.
Thanks very much.
Thank you, everybody.
Thank you. Members, coming out of that, there's a couple of things that I think we should be writing to the Minister and the Department on. Firstly, I suppose the survey that the representatives have alluded to in terms of recruitment and retention, and the lack of progress and implementation of that. So if we could get an update on that, if people are happy enough. The other one is in relation to recruitment, and the numbers of newly qualified nurses coming out, the high number of vacancies, but we don't know how many of those are being recruited for. So if that's clear enough, Keith, we would need to get some clarity around that, because certainly it's something I've raised it with one of the trusts about some of the rumours, perceptions out there for nurses who are due to qualify now in June, being told that there's no jobs for them, and we don't know how true that is. Colin?
Can I ask again about our potential for an engagement with the Minister? I know we had said that we meet quarterly and whatever, and I mean, I would lay this down as a marker and saying that I think we should have a no blame meeting with the Minister, but I think we need to have it urgently. What we heard today was that our system is killing people. We're the scrutiny committee. I know that I'm certainly going to have difficulty sleeping tonight, thinking that we are charged in this place with scrutinising the department whenever the professionals come in and tell us that the system that's there, this is not the people, the system that we have in place is killing people. And I think that we need to be satisfied as a scrutiny committee that there is work happening, and I know that there is not no work happening. I know that stuff is happening down in the department, but we haven't got a flavour what it is that's happening, what the timescales are, what the delivery is going to be, what it's going to look like, how it's going to be shaped. I think I just need to know, yes, we know there's a problem with this and we're doing X, Y and Z. We'll be coming back to you in 6 months. We know there's an issue with staffing. There's a team that's looking at it. They're going to come back in a year. I think we need to know it, or otherwise we just as a scrutiny committee are not doing our job. So, and whether that's a lunchtime meeting at some Monday or Tuesday with the Minister, but I think if we were in a room just to get the assurance that we know it is happening, then at least we can say, well, then we can look at it coming down the line future. But if we wait 3 months before we meet again and hear that something isn't happening, I think it falls back to us, and I think that's our job. So could we seek an urgent meeting? No blame, we're not going to a meeting to blame the Minister or blame the department, just to have a meeting so that the Minister can tell us that things are happening and a bit of a time scale about it, and then at least we can leave that meeting and go, well, as a scrutiny committee, we've done our checks to make sure that something's happening.
I have no issue with that. I suppose what I was
It's not an issue, but where you can bring the Minister along and you can ask him all those questions, and he'll probably give you the stock answer, as will all the ministers and all the departments. I don't know my budget yet. I don't know what I have to spend. I mean, we read yesterday about the gap between what all the ministers are asking for and what's available, and we've heard in that conversation that the Department of Health would need the entire budget just to stand still for a year. That's devastating. So we need some clarity around what budget the Department of Health is going to have, and then we need to have an input into what we think are the priorities. But if anybody thinks that there's a magic wand solution here, there's really not. I think the Department, the Minister, is going to need all the help that he can get from us politically to shape the future with the money that he's eventually going to get, and we don't know what that is. That figure is going to be.
Well, I suppose what I was going to say there, Alan, is that yes, I agree that will probably be the response, but I'm assuming that we will be hopefully seeing a budget fairly soon, and that the Minister will be coming to brief us on that. That's certainly my understanding.
We've requested it. We've initially been told he's not available Thursdays in May because of the COVID inquiry is booked out, and we're looking at possible other dates.
So that's in the next
it might coincide in the end anyway, so we can put the...
Yeah, so what I also was going to suggest then on that is that we obviously have our planning day next week. I think we need to figure out what, all of those things that we want to hear those updates on, because there's a whole raft of things there that we do want to hear updates on, and it isn't just about money, as I've said there very clearly. It's about how are we looking at how to do things differently. So I think maybe next week, if we can crystallise some of that stuff, and we have a request in, and if it's on a different day to our committee's day, I'm more than happy to do that. I think that's
again, just be clear. It's not It's not to bring a minister in and blame a minister on it. But I think that it's incumbent upon us to know that it's happening. Yeah. There's a COVID inquiry, as you mentioned now. If in a year's time there's some sort of inquiry because our health services collapsed, I know that somebody is going to point and say, "Well, you were told on the 18th of April that people are dying because they're on a waiting list, and if it's them, will you wait another 2.5 months before you ask the minister something?" I just think that we need to cover ourselves by making sure that we're doing that scrutiny role of just asking, definitely on the record, are things happening? Yes, then we can satisfy and say, well, then you're doing stuff, and we can scrutinise it, it's going along. But just whenever you hear the likes of that today, I just don't think that we can sit back and say...
Before I take Linda because I have a few people waiting, before I take Linda in, to me that's not a surprise that people are down on a wait list. We've known that. So I think what we've been trying to do in the course of the committee to date is to get the detailed information as to why that's been happening and what needs to happen to make that change, and that's the solutions. And everybody that we have met to date has been providing solutions. So what we as a committee, I think, need to be doing is making sure that the Minister and his department are hearing that and they're actually taking that on board. So that's why I'm saying when we come together as a committee next week, I know it's probably separate to our strategic priorities as a committee, but for that meeting that we are saying, right, these are the things we need to get information on, updates on, and it's not good enough, I don't think, to be saying, are you doing something on it? Yes, let's move on. I think we need to be saying, what are you doing? What impact will this make? And when we look at the budget picture, in the absence of the right money needed, what can we do? Because that's also going to be an issue. So there's a lot more detail, I think, that we need to be asking around that. So if Linda, then Nuala, then Alan.
To be fair, Chair, it's okay. You've actually covered it. I think I would like to have that conversation ourselves in terms of the meeting next week about what we would be asking for all those reasons, because I could ask him a million things but might be the right things. And I agree with everything that's been said. It's not about blame. It's not about budget actually either. Massively important as it is. We know none of these departments are getting what they need. We know that. but it's what are we going to spend it on? What are we going to use what we have on? What do we see as the things that absolutely have to be done and can really make a difference? So I want to get my head around that, because you're right, Colin, we're an accountability mechanism, but I can't hold anybody accountable if I don't understand what's going on. So I need to understand that. And so I think what everybody said is actually covered my points in fairness.
I agreed with what you said, Chair. I also understand where Colin's coming from, but I do want to say that it's not just about us covering ourselves as a committee. I think detail is very, very important, because we've already asked detailed questions. I know I've asked questions by already doing the work behind the scenes to know what the answer's going to be, and then them not giving them the answer. And that was being very frustrating. But I think that kind of detail work is important, that we kind of keep that up. So I would I agree with everything that you say in terms of like having the conversation with ourselves. But one thing I think we should put on the record for next week is that I don't know how we do this. We kind of people cannot answer how they wish. You can't compel them to answer a way in which you want. Otherwise, what's the point in having that free speech to answer? But before funding, the answer was always COVID. COVID pressure, funding pressure. What's going to be the next answer? Like, so I do think that that's why we need to do the detailed work, because the excuse was COVID. The excuse is now funding, and yes, there might be funding pressures, but it just doesn't always fly. Like I said, we need to sometimes do things differently with what we've got. So I think it's important we do this detail first on it, so we'd support that.
Alan?
Just, I don't know how the system works around this, but we've heard today, and Colin's picked up on it, that when he asked the question, people are dying on a waiting list. That's the reality of life. People die. They may not be dying because they're on the waiting list. There might be other issues, but if they're on a waiting list and they've died, well, you can point that finger. But say you're the patient and you're number 5,000, patient number 5,000 on the waiting list, when you really need to be patient number 1 or patient number 10. Is it a lottery? Do you just go on a list, or is it reviewed? The clinicians look at these lists and say, look, that patient there needs to be number 5,000. They need to be up there. They need to be in the first 100. And that person that's sitting at number 2 at the minute in the list, they can go back to 5,000 because their needs not as urgent. So I'm just wondering, are waiting lists routinely reviewed? I'm sure it'd be a heck of a job to do it. But I'm wondering, is there any panel that sits and looks at a waiting list and says, let's pluck out the people who could die because they're on this waiting list, and let's do something for those people?
Okay, fair enough. So we're happy enough then that we...
Diane.
Oh, sorry, Diane, I didn't see your hand up.
That's okay. Thank you. I do think that we do need to do a little bit of work of what we expect the minister to give to us. I mean, I am constantly frightened by what I hear in terms of evidence at this committee. And I know that the minister won't get all the money he wants, but nevertheless, there are things that can be done or things that we could be asking. And I think I agree with Nuala that we would need to actually know exactly what we want to ask and how we think that those solutions might look like. Nuala is quite right. We've had COVID as an excuse. We don't want funding to be an excuse to do nothing. And if the minister comes back and says, well, I need another £1 billion, but I'm going to stand still and I'm going to continue to deliver the same per service that I have with all of the additional money, I don't think that's good enough. And we need to be asking him how he intends to improve that situation.
Yeah, no, absolutely, and that's kind of where I was coming at as well, Diane. I think that's key to all of this. So, I think we're all agreed on that course of action. If you're happy enough to move on, then members, we've got 2 SRs. So, item number 8 is SR 2024-49, the Health and Social Care Pension Scheme Amendment Regulations Northern Ireland 2024. If I can refer you to page 75. This statutory rule follows the regular 4-year review of the HSC pension scheme and will introduce changes to the employer contribution rate from the 1st of April 2024. If we could advise members that the examiner for statutory rules had no comments to make, are members content with the rule? Yes. Yep. So the Committee for Health has considered SR 2024-49, the Health and Social Care Pension Scheme Amendment Regulations, Northern Ireland 2024, and had no objection to the rule. Item number 9 then is SR 2024-50, the Health and Social Care Pension Schemes, Partial Retirement, etc. Regulations, Northern Ireland 2024. I'll refer you to page 88 of your pack. This statutory rule brings into alignment all members of the HSC pension scheme, both the current 2015 scheme and closed 1988 scheme, aligned under the MacLeod remedy. It will provide a package of new retirement flexibilities. It will include pensionable re-employment, partial retirement and permanent removal of the 16-hour rule, and the examiner for statutory rules had no comments to make on this or SR members' content.
Yes.
So the Committee for Health has considered SR 2024-50, the Health and Social Care Pension Schemes, Partial Retirement, etc. Regulations, Northern Ireland 2024, and has no objection to the rule. Members, item number 10 is correspondence. If I could refer you to the correspondence list at tab 10, pages 120 to 205. There's a couple of items I just want to draw your attention to. As I've mentioned earlier on in the first briefing around the Minister's response regarding waiting lists, members, some people may have something to raise. I know certainly I wasn't satisfied with the response that was received. I think, again, we've been asking for a breakdown of the money that has been quoted as required to address waiting lists. At number point 7 on the letter, we've been given some examples of the approximate costs. I don't really understand where that cost comes from. For example, 1,100 patients waiting on tonsillectomies over 4 years, approximate cost 3.5 million. I would like to have a better understanding of that breakdown as to how that will be used to tackle waiting lists. So what will that mean? That these people will have cleared our waiting lists in a year?
How many for the 3.5 million? That's
That's so I feel like we're doing a wee bit of back and forth here, but we need to get this sort of information. And we've only 5 examples there of waiting lists. For me, there's a lot more. We've heard some of the impacts of it today in our briefing. So if possible, I would ask members for agreement to go back to the Minister to ask for further detail on those figures as to what impact that will make and how, if that's clear enough, Nuala.
Yeah. Perhaps also then include maybe Alan's one of Alan's concerns around the prioritisation of waiting lists, and does it always depend on the health outcomes that, you know, if they're worse at that stage the boost? Because remember, we had officials in who said actually they are looking at targeting long waiters as well. So how are they dividing up 135 million? Is it just long waiters? Is it those who are in a worst health state? I don't know. Is it in a poor health condition? You know, so
is it reviewed to reassess
so
who needs to be where?
If that is also included, that would actually be helpful too. I mean, I'm not to say that we are clinicians, because we're not, but you know, if we are to do the work of the clinicians who are asking the questions and raising them with us, if they're not being listened to, it's just to see where's that kind of collegiate approach to the best way to tackle it.
Yeah. Linda, did you want to come in there?
That is actually covered.
Yeah,
Sorry,
no, that's
yes.
fair enough.
Yeah.
The only, and just I suppose as well, and I did mention it earlier, and I suppose followed up with an action, but the bile cancer treatment waiting times are absolutely shocking. And I know every week we're seeing really stark figures, but when people aren't seen within a 31-day target from when they're diagnosed to their first treatment, isn't that right? It's over 90% for most trusts, with the exception of the Southern Trust, which is 79%. So South Eastern Trust there is 99% of people aren't being seen within that 31-day window. So 1% of people.
Oh, that's are being seen.
Oh, sorry,
So
sorry. I'm looking at the 62-day, but it's not. It's not very different. So what it is the 62-day performance. So from your first red flagged or referred by your GP to the date of your first treatment, only 19% in Belfast Trust, 10% in Northern Trust, and you can see the rest of the figures. So on scale, you're talking about roughly 80% of people are not being seen within that 62-day, and it appears that the delay is in that initial period from first referral to their diagnostic. So it ties in with what the point I made around in my own area in Daisy Hill. I'm conscious there's a scanner in place that's not being used outside of current hours, whether it's over the weekend or that potentially we should be looking at. So I just wanted to flag it up. We have already, I suppose, an action coming out of that if members are happy enough. But I just think it's a very important one when you look at those figures that we're only meeting. 22% is the highest that we're meeting in targets there. Now, like you had raised, you'd asked us to put the dental amalgam issue back on at 10.4, so just if there's anything you want to raise in the response.
Yes, no, under the item, well, I don't need the letter, but I just think it is important that this issue is addressed by the committee, and I understand in his answer in the chamber that the Minister of Health said that and really alluded to a fact that it should be the Minister of Agriculture, Environment and Rural Affairs who should be the lead on this, but it is the Department of Health who has eroded the dental industry and the sector over the years to the point where now, whenever this ban does come into force, it's just going to have such an even bigger negative effect, and therefore that the Department of Health should be doing as much as they possibly can to mitigate. So I just wanted to propose, if we as a committee, and I understand that the Democratic Scrutiny Committee has met today and they may have had similar conversations, but that if we could propose as a committee that we write to the Minister to request that he seek a derogation, and that the committee is in support of that, because I think it's important that we do all get behind it, you know, and acting as you know, one committee on the matter. I think because the department and it has been for a long time, so it isn't just one individual minister's you know, fault. I don't want to just put blame, but the dentists have been underfunded. We are seeing more NHS dentists close and more will be at risk, and certainly the figure presented to the committee, the 3.4 million I think it was given as to what cost it would be to the department, I don't think is an actual real cost, because that's just the initial financial, not the actual real cost. So I think it might be important that we do. I'm happy if we need further evidence sessions on that, but I understand that the Windsor Framework committee has also done in-depth evidence. So if members, even if members are happy to speak to their colleagues in that committee and come back next week, rather than putting the proposal now, but that is what I'm.
And we have the BDA coming in, don't we?
Chief Dental Officer and the BDA scheduled to appear before the committee in June.
That's and that's already a bit too late. So we really do need to support the issue of derogation as urgently as
But if maybe then for next week, then we have a discussion, suppose, with members of the.
Maybe just build that. If the minister said that there was no, or that it wasn't his responsibility, could we maybe, as part of the letter, clearly ask him to explain what is his responsibility? Because at the end of the day, if we ask him something that's not his responsibility, he's just going to simply write back and say it's not my responsibility. Whereas if we have that at the start, what is your responsibility and what isn't? Because we'd need to.
Diane, sorry, you're looking at.
Yeah, no. It just is. I think it is actually really important to hear from the minister or departmental officials again. When the minister was in the committee, I asked him how much the ban would what the cost to the health service would be, and his finance official indicated that it was just over 200,000 that they had actually asked for. And now we hear from the Windsor Framework Committee a figure of over 3 million. I have actually spoken to the British Dental Association, and they said that is nowhere near the cost it would be if there isn't a derogation from this. And I mean, Lou is quite right. With dental services are hugely under pressure. NHS dental services are massively queued out. It's very difficult for families to get services, and we do need to have an idea of the cost. I mean, and we need to have a little bit more clarity than we currently have. There's a lot of figures being thrown about, but not much clarity on how they arrived at them.
Yeah, no, I think that's fair enough. Yeah.
Do you want me to take it back next week then?
We'll have our plan there, so we can maybe discuss it then in our next step. So, thank you. Members, there's just one. I wanted just to refer, and I'm so sorry because I know the time. The letter from my colleague Chris Hazard in relation to the NIAS handover times at hospitals and something obviously we're very aware of, and we had Michael Bloomfield here a number of weeks ago. I was just going to ask if we could, just in terms of the issues raised around training and things like that, would it be possible right to the department just to get some feedback on that, because if there's things that we can be doing, I think we should be on relation, because some of those times are horrendous, and we are aware of that as it is. Are members then content to note the actions of the remaining correspondence? Sorry, Nuala, go on.
Sorry, Chair, I know, I'm sorry. I keep going on, but there are important issues, and it's with regards to 10.5, the update on the Regional Care and Justice Campus programme. And you would be led to believe within the correspondence that everything is going well at Lakewood, and that Lakewood's just fantastic. But that's just not the case, and we are hearing from the sector that both work and not just legally and lobby groups and you know people who represent those, particularly young people that are in quite a lot of distress, that it's not. And I think it's important that we do need to actually have more of an in-depth look, particularly at this service, because I am and do have concerns around this kind of shared standard approach from the Department of Health, because Woodlands and Lakewood are two very different things, and the shared standards, I'm not sure what's meant by it, but also I do think that there needs to be a reality check that it's not all great as it's put on here. So I'm just kind of looking and seeking guidance perhaps from the clerk with regards to exploring that further with the department. Should we put it on our strategic planning day, or ask the departments to come in when it comes to the likes of children's services like Lakewood, Beechcroft, for example?
And the members to decide what they want to do with it.
Do you want to maybe look at it next week then and say how
If
we
we
proceed with that?
If we put it on next week, yeah.
Because I don't want to rush something and then it not being.
That's okay. I just wanted to flag it to the attention.
No, I think that's a good point. So thank you for that, Nuala. Are members content to note the actions on the remaining correspondence as listed? Yeah. Thank you. And excuse me, right? I have a head cold as well, so I'm getting quite nasally. Item number 11 then is the forward work programme, which is at tab 11 of your pack, page 207. Members will know that we have an informal meeting which has been confirmed with Mesh Ireland at 2 p.m. on Monday the 22nd of April. That's this Monday coming, and an invite will be issued in relation to that. And next Thursday the 25th of April we have our committee strategic planning day, as we've been talking about, at NICFA offices in Duncrown Gardens. The committee will receive a welcome and short brief from NICFA. Then a number of organisations will brief members informally, and following that we will have our strategic planning day. Details have been issued to members. Lunch will be provided, and please inform the team of any allergies in advance. So to prepare for an effective engagement on the day, and we've loads of things even coming out of today's meeting, the committee office is asking for members' priorities now. So if you could email the clerk, who will collate these in preparation for discussion on the day. So far, only one member has replied, and that's not me. So I'll hold up my hands to say that I'm not leading by example. But I think it is important to allow the clerk and the committee team.
Excuse me, Chair. Some of us have done it verbally every single week. So it was just like that, and it was okay.
We might need a book now then. So just if we could do that, I think that would be useful for the committee staff and team as well. So members, are you content to note the briefings as set out in the forward work programme?
Yep.
Thank you. Any other business?
Very quick one, Chairman. Just over the last sort of week or 10 days, a couple of my family have had occasion to attend action and emergency departments. Great service, great treatment, everything. But they were saying that the number, it's like a family outing sometimes. Some of the patients maybe have 4 or 5 family members with them. And I know that one patient that had been triaged, but who had presented after having a collapse, couldn't get a seat after they'd been triaged. And I'm just wondering, do the various trusts have any regulations around how many
Policies
people, if we could maybe find that out, it might be useful. But it puts more pressure on all the facilities, toilet facilities, everything. If a patient's there with 4 or 5 people with them, it's not really, they don't really require that sort of amount of support, you know. But maybe just a question we could ask the trusts.
Yeah, Danny, did you want to just...
Certainly, it's my experience. People should have one person with them, and I know that it is a thing in waiting rooms that you do have a lot of people who do come in, and I know that sisters in A&Es do try to enforce the person, but I think it's very valid to ask.
It's important to ask, but I think we also need to be mindful we don't want to put staff in a position where they're having to move people out because we don't want to cause them any hassle either. But again, I totally take your point. I think it's an important point to raise. Thank you. Members, date, time and place of next meeting. So as mentioned, is next Thursday 25th of April at 12:15 in NICFA headquarters. And although it will be an informal setting, we still have to formally agree the LCM on the tobacco and vapes bill. So members, thank you. We did all right, and then we're well over time now.
Committee Room 29. Sound. Committee Room 29. Sound.